Surgical Skills Lab that's available year-round for both learning techniques, but also doing different anatomical studies and those types of things. Again, trying to learn a little bit more about what we can do surgically or procedurally now and in the future. We got a great cohort of speakers today. Many of these faces you've known or worked with, what we're really trying to do, of course, is create a forum. We're trying to create a forum for learning about cases, but also learning to speak to each other. We have a lot of different ways that we think about anatomy and treatment. It creates a great forum for us to discuss cases, discuss different types of techniques, but also reasons to do procedures and reasons to not do them. I'd like to thank our sponsors. We've got the cadaveric specimens don't come for free, so that's most of what the funding is for. Although the food you're eating now too is paid for, these are ways that we really get some help in learning, and then again also some interaction with reps so that you can learn how to work with them. We will be taking photos, potentially some videos. Of course, we're recording some of these talks, and then some things will go on social media. If you do not want to be on social media, please let us know, and we'll try to avoid taking pictures of you. So today we're gonna start out talking about lumbar spinal stenosis, then cervical disc herniations, degenerative scoliosis, and then neck pain or cervicalgia. So that's our big discussion topics today. Tomorrow, for all of those of you who are going to attend, we're going to start with posterior approaches to the spine, and tomorrow's the big day. So tomorrow's the most involved day, just because there's a lot more approaches to do and techniques to do. So plan to come and plan to stick around, and we'll go from the skull all the way down to the pelvis, and so that'll be a great experience for learning. And then Sunday is all the anterior approaches, and we do that throughout the day. And as I've always say, year to year, once you're going to do the abdominal approaches, please make that towards the end of the day, just because sometimes it can get a little smelly. Although we have new cadaver specimens this year, so we'll see how things go. Okay, so our first speaker, or our first two speakers, are going to be Dr. Sewer and Dr. Burkett, talking about lumbar spinal stenosis. What we're really learning, again, is going to be the non-operative management, followed by the operative management. They're going to give a little bit of a discussion about data and procedures, and then we will discuss a couple cases. Please feel free to ask questions or speak at any time, just so that we can get clarity. But we also want this to be more of a discussion than just a strict didactic lecture. Thank you.
All right. So like I said, I'm Michael Sewer. I'm one of the PM&R pain providers working predominantly in the spine clinic, doing some procedures as well. With all of this, I think most of us are familiar with a lot of the spine topics, especially as it comes to like pathophysiology and exactly what's going on in the spine. So there's not going to be anything, as groundbreaking as the shovel in here, but hopefully shed some light on why in rehab we do what we do. So as far as the pathophysiology goes, most cases of stenosis are acquired. We do have some people with congenitally narrow pedicles, and so they start with a tighter baseline. But it all comes down to compression. Compression, ischemia, there's questionable role of how much actual inflammation is going on with all of this. There's not really been definitive research to demonstrate a significant amount of inflammation, but there has been some that has shown a little bit of inflammation associated with it. But as we all know, it's predominantly a compressive pathology. As far as what patients present with, I think it's a little bit different in the surgical clinics versus the rehab clinics. In the rehab clinics, we do tend to see quite a few people with predominant low back pain. A lot of these cases, it is both due to stenosis as well as potentially facet arthropathy, myofascial pain, SI joint issues. And so a lot of what we try to do is tease apart how much of this is related to stenosis versus facet-mediated pain or some type of joint type pain. Some of the things that can help us differentiate that is the classic things you know about arthritis with the morning stiffness versus the more posture-related pain that you would see in a stenosis picture. But again, a lot of these patients have both, where they'll say, I wake up and I'm stiff and I'm sore. 20, 30 minutes later, I'm feeling pretty good, but I have a really hard time walking. Anytime I get up and I go to walk, you know, it hurts a lot. I lean forward, go to the grocery, use the shopping cart, things are better. But then if I have a long day, if I'm out doing a lot of stuff, you know, shoveling snow on the 1 week that we have it a year, my back really is sore for a day or two afterward. And that is a little bit more of a facet picture, but we have that stenotic picture where there's that posture dependent back pain. Now, most of these, you know, are going to come in and have a little bit different picture where they have the pain going down into the legs, plus or minus the back pain. And this, you know, when you look at this claudicatory pain, it's a similar posture dependent, ambulatory dependent type of pain. The differentiation here is vascular versus spinal sources. Spinal tend to be very, very posture dependent, as I previously said, whereas the vascular is more duration of walking dependent, where they'll be able to walk for a quarter mile, half mile before they inevitably get the cramping in their legs. And it doesn't matter if they are walking upright or leaning forward. Now, as far as the exam goes, with most of these, they're going to have a normal neurologic exam. Having a positive straight leg raise is pretty rare in a true stenosis type picture. However, they may present with a single versus multiple radiculopathies. And this is actually one I just did an injection for an hour ago. Looks like a bilateral L5, but it's very, very posture dependent. And when you look at the MRI, there are multiple levels that are narrowed. And so with that, I'm looking at that going, well, is this a true radiculopathy picture, or is this spinal stenosis with claudication picture? And some of these have quite a bit of overlap. One of the hard things on this too is when you start looking at gait, a lot of these individuals will lean forward at the waist, or they'll do a pelvic tilt where they'll be upright in the thoracic cervical spine, but they'll tilt their pelvis forward, essentially flexing the lumbar spine. So those things, when you watch these patients walk, you want to look for that. Changing different speeds that they walk can be important too, to see if there is any nerve issues potentially causing some weakness as they're ambulating a little bit quicker. Some even more subtle things, walking on uneven surfaces, feeling some instability in their ankles or legs, just with the difficulties that come with varied surfaces. As far as treatments, which is the bulk of what we are really here to talk about, I usually look at this from conservative up to most invasive. And so 4 different main buckets that we go into. The first one being the simple stuff: physical therapy, chiropractor, massage, lumbar bracing we throw into there. I'm not going to touch too much on physical therapy today, but as far as bracing goes, this is something that a lot of patients have tried even before they come into our clinic. They go to Walgreens, they pick up a little back brace, they throw it on just to see, hey, my back hurts, maybe this is going to help. Most research, and subjectively it's true as well, is that it's about 50-50. Some patients get relief, some patients don't. But the perks is that it's non-invasive. You're not using a medication, very inexpensive. You can use it immediately. However, there are some restrictions with bracing, specifically as it relates to weakness, which is something that a lot of us talk about, is that if you use a brace all the time, your muscle's going to get weak. And are there ways that we can counteract that, perhaps working with physical therapy on strength, so that while we're using the brace to improve function, perhaps we can negate some of that weakness that may develop by being proactive with strength training with physical therapy. Some of the other things to consider is just a lot of different types of braces that you don't always know what you're going to be grabbing, if they're getting the right brace that's actually fit for them, and then some weight restrictions as well. With a brace, you're really looking at abdominal compression, and so you want to have something that's nice and tight. If someone weighs, has a BMI 30, 35, 40, 45, you may not get that same compressive force on there. Most of the time in our clinics, we're using lumbar corset type braces, which go around the low back, have an initial Velcro strap that closes, and then additional Velcro straps that help pull it a little bit tighter. And these are available in our orthotics group. So if you're seeing someone in clinic for that, may or may not make you look like Mario Lopez or something there, but hey, maybe. As far as actual research on here, there's very, very little research on bracing for stenosis, especially with neurogenic claudication. Essentially, with bracing, some people had improved daily pain scores and ability to walk. They didn't actually look at how long this relief lasted, though. So a limitation of the study that maybe it helps. I don't know how long it's going to help. And that's something I'll tell patients, too, that even if this helps, I don't know what's going to look like in 3 months, 6 months, 12 months down the road. Overall advice, make sure it fits well, make sure it's comfortable, because even if it helps, if it's a wonderful treatment, but it's uncomfortable, people aren't going to wear it. And then when they put it on, make sure that it's sized appropriately so it actually feels supported. I also tell people, just in case there is muscle weakness, don't wear it around the clock, but use it to increase the amount of activities that you're able to do. As far as medications go, there's a lot of options. What options are actually the best is really, really patient dependent. So when we look at broad medication categories, anti-inflammatories, they've done a systematic review on that, and it's probably effective short term. However, with a lot of our patients, and they get stenosis, they're older, so you have to look at kidney function, liver function, cardiac function to make sure that you're not causing more harm than good. Effect with these is relatively small. Typically, these are used for more mechanical type pain, joint type pain, rather than the neuropathic pain we'd see with stenosis. For the neuropathic pain, however, the classic medications we use, gabapentin, Lyrica, Cymbalta, some of the other antidepressants, certainly are useful, and research has demonstrated that. But again, we start looking at other side effects. Instead of the kidney issues, liver issues, more the mental fogginess, sleepiness that you could get with some of these medications. And making sure that a medication is worthwhile. If the patient really only has pain when they're up walking around, do we really want to start a medication? Is it worth the benefit they would get with that? And that's a discussion that's very patient dependent, and what they're willing to take on, and really how they interact with medications just in their history. There are some patients that come in and say, I've heard all about this gabapentin, Lyrica stuff, and I don't want anything to do with it. And at that point, I just kind of skip the conversation as far as those two meds go. Going on to injections, which, from a surgery standpoint, this is what you're most going to be interacting with. The question comes about, are they really helpful? And from a rehab standpoint, we would define helpful as decreasing pain, but more importantly, improving function. With stenosis, we're really looking at walking. We want to make sure they can walk less pain, be able to do simple things like go to the grocery store, walk around just to get some exercise. The caveat with the injections is that we're treating stenosis. We are not treating facet arthritis. We're not treating SI joint issues. We're not treating muscular issues. And so discussing these with patients, we need to have a realistic expectation of what we are and we are not treating. And the best outcome is really going to come from having those discussions before it's even placed as far as what the goals are of the treatment. Other things that injections are used for, not only to rule in stenosis, but to rule out other causes of pain. So an epidural injection is not going to help vascular claudication, not going to help neuropathy, any rheumatologic conditions, it's not going to help either. There we go. As far as effectiveness, the biggest research study we have on this really comes from the VA. And looking at Medicare populations, VA populations, these injections are incredibly popular. And by popular, I just mean well done. How much patients love them is a different story. But what we have found is that overall they are helpful. How long they're helpful is to be determined. We don't really know. We certainly have patients that get 1 or 2 of these injections and they feel great for months or even years. Other people, they get weeks of relief. And in that case, maybe we have diagnosed where the pain is coming from, but not treated it. I mentioned earlier that we don't really know exactly how much of an inflammatory response is here. And we typically use steroid. This is one area where they have actually tried to delve into that research to see if steroids are useful, because if steroids are, then that would indicate more of a inflammatory response. However, we're also dealing with the negative consequences of steroids if we use them too much. Again, our goal, suppress pain, improve function, and then identifying that source of pain. For research on epidural injections, it gets really hard to break apart the different causes of the reasons they're doing these injections. A lot of times they're grouped all together. And so they'll group together acute radiculopathy, chronic radiculopathy, spinal stenosis with claudication, spinal stenosis without claudication, and just throw them all in together and say, is it effective or not? And that gets really, really then hard to determine how effective these injections are. To the best knowledge, we can say that they are. Evidence is not compelling, but it's there. They're not universally effective. And I think we know that with anything. Medications, physical therapy, bracing, nothing is universally effective. So that makes it difficult. Best results, single contained disc herniations with a single root radiculopathy or radicular type pain. There was a trial, again, going back to the inflammatory component, that generated a lot of buzz in the pain world, where they looked at the steroid effect with these injections. And essentially, they had groups of patients that came in, got injections, plus or minus steroid, looked at them 6 weeks later. Essentially, they came out and said, there is no effect of a steroid. But when you look into the methods of the study, there are some issues there where when we look at it, we would say, well, this doesn't actually match our patient population. So it's hard to take this research into the real world because it just doesn't totally match up, including not even looking at walking tolerance. This is one of the big things we look for from a functional improvement standpoint. As far as performing epidural injections goes, these can sometimes be a little bit tricky, but a couple of things we want to consider. So if we look at a patient like this, I think all of us can see the level of stenosis. And so ideally you would say, well, just inject right at the level of stenosis. But some considerations from a pain standpoint that we would look at would be, is there enough space to get into there? And if there isn't, where else should we do the injection, where we're actually going to have a diagnostic plus a therapeutic value? So we see the stenosis here. I would argue there's probably not enough space there to safely get the injection in. Maybe you could. If you're better than I am, you could, but I don't think I would have the guts to stick a needle right into there. So you'd say, well, let's go below, because it's likely going to spread up. And again, we run the same problem where, well, I don't think there's enough space there to safely stick a needle into it. Well, then let's go above. And that may be our best option. When we look at the injection and how much it actually spreads, it's going to spread up a little bit better than it spreads down. So if we go at that L3, L4 level above the level of stenosis, what we're going to see is that it's going to spread up to L2, 3, maybe get down to L4, 5, but from a diagnostic value, we're really not going to see a lot of spread down to where that stenosis is. So this may not be the best approach to it. Perhaps doing a caudal epidural steroid injection would be better, less specific getting to that area. You could also argue for bilateral L5 injections to really try to hit that L4, L5 level, or even bilateral 4, 5 levels. As far as the actual injections themselves, I think someone's going to talk about this a little bit later, but wanted to make sure we saw a little bit of it here. As far as what these injections look like.
Don't mind, I was going to ask her, make a comment on the last one, just from the standpoint. So many times we are the ones ordering these injections. And I know you guys can change them, but in some practices, it's just like whatever the order says, that's what you're planning to do. What would be the most likely recommendation that based off just the anatomy from this that you would think would be the,
if I were
how
doing
would you
it,
do it? Yeah.
If I were doing it, I would do bilateral L5 transforaminal epidural injections. And the reason is, I think it would give you a little bit more specificity that we're injecting right at that L5 level and then seeing it spread up into the L4, 5 where that actual stenosis is.
Right.
From a safety standpoint, I wouldn't be super comfortable doing L4, 5 or L5S1.
Midline.
Correct, midline.
Yeah.
If we were just going for non-diagnostic, we didn't care, we just wanted it in there. From a safety standpoint, I may say a caudal epidural. But from a safety standpoint, it's really nice but it's going to be the largest spread. So you're not going to get the specificity you would want with a bilateral L5.
So I just want to make a little comment, maybe a little bit of translation for the residents and the surgical side. When you're saying bilateral L5 transfemoral injection, what that means is an L4-5 transfemoral injection. In our that's how we talk. From the rehab pain perspective, they're often targeting the particular nerve rather than the particular foramen. So it's just so that you kind of understand that clarity.
And ordering it, you can order either one. You can order bilateral L4-5. You can order bilateral L4 versus bilateral L5. My default, when it's that stenotic, is to go right below the level that we're going to be going at. So on this one, I'd probably do bilateral, like L5S1, to come in and then go up to that L4 or 5 level. So if we look, and this is kind of what I'm talking about, I skipped ahead here, but if this is a transforaminal epidural, so you see the needle coming in from the left, and it's sitting right underneath the pedicle, which I circled there in yellow. And you want that to be sitting about 6 o'clock on the pedicle. And you want to see the contrast flowing medial to the pedicle and then up. And so if we were to have stenosis above, so if we were to have the stenosis right up and through this level here, you can see that contrast really nicely coming in and then flowing up to that level of stenosis. And that's just a visual representation there of it coming up a little bit more than it's going down. So that's what we look for in those. A caudal epidural steroid injection, which is, here coming in through the tailbone, it's a high volume injection. So we're putting in about 7 mLs worth of local plus dexamethasone, and it's going to spread up quite a bit, even to L3, L4, some people even a little bit higher, but it's going to hit both sides. It's going to hit everything from the lower lumbar through the sacral roots. And so it loses that specificity. But this is what we're looking at here with a caudal injection. We see on the right side of the screen, the needle coming in through the sacral hiatus and having the contrast anterior to that posterior border of the sacrum. On the left side is the AP view. And we typically want to see what they call a Christmas tree pattern, but essentially the contrast going up through the middle and then coming down each one of the individual nerve roots. And that lets us know we got the injection into the correct spot. All right, with that, any other questions? Otherwise, I will take my seat here.
Perfect.
Yes.
Don't forget, we need to get you the microphone.
Hang on one
second.
The question too.
You're so far away. Sorry. That's good. It's okay. Simon, you got it? That makes it a lot more fun, but apparently we can do that. Yeah.
Okay. So we're running into a lot of issues with ordering injections, especially transforaminal ones, where the surgeons want a single nerve root, but IR always sends it back to us saying we need to say the specific 2 levels intervertebral levels. So we can no longer order it as a single nerve root. We have to order it as an L3-4.
Yeah, so there's a slightly different ordering process just in Epic, and I can tell you about it later if you want to, but there's a different ordering process for the pain doctors at MSC versus interventional radiology. So if you wanted to do bilateral L4-5 transforaminal epidural steroid injection through MSC, you could order that, bilateral L4-5 transforaminal epidural. With radiology, it's 2 separate orders, a right L4-5 transforaminal epidural steroid injection and a left L4-5 transforaminal epidural steroid injection. So if you want it through IR, it's 2 separate orders, but through MSC with the pain doctors, it's just a single order, and you can order multiple things on the one thing, separate order in Epic.
So from kind of from that perspective, what I've had conversations with interventional radiology, rehab, and then also interventional pain, which is anesthesia, about how we could try and combine the order into one thing. It's still kind of a lot of work to discuss, but the reality is that radiology really wanted to have a lot of specificity to make their workflow easier. But I'll tell you which order I put in the most is rehab, because I don't have to think about any of that stuff. And I never get called back about it. And so I'll let you know, just because all I have to do is type whatever I want. You guys figure it out. It makes it a lot easier.
And Yeah, and if
Yeah.
we have questions, we'll message you, but we'll also, see and evaluate the patient before we do it. And if something needs changed, we will talk to you before we do it.
Yeah.
Change it only if necessary.
But I think from the standpoint of, working within whatever healthcare system, you also have to keep that piece in mind. So obviously we have a bunch of different providers that do injections, so it makes it a little bit different. And that's what you guys are seeing when you're ordering from one particular order versus the other. But as you're out in practice, you may find that you're working with somebody who's an anesthesiologist, and they're just kind of convention of naming the target as the same as yours or different, or it's rehab and same or different. So that brings up all those issues. Yeah. Okay, Dr. Burkett is next. You want to lapel, or you just want to talk on that? You can just. He was just talking on that. Okay, great. So we'll talk about the surgical side, and then we have a couple cases, and as you can tell, we're not totally on time, but we'll catch up. It'll be okay.
Display swap. I don't know why it does that, but awesome. Thank you. All right.
When do you start over at St. Mary's?
July 29th.
Okay, so on July 20 to July 30th, you can refer all BMI over 40 to St. Mary's.
Well, I mean, endoscopic, which this isn't talk isn't about. Happy to take care of them. Just got to get the longer scope. So I'm Dan Burkett. I'm the Infolded Spine Fellow currently, and like Dr. Brooks said, I'll be at St. Mary's next year, just downtown. So Dr. Stewart had a great discussion, great overview of spinal stenosis. So these next few slides will just touch briefly on, but kind of the big thing for us as surgeons is really identifying where the location of stenosis is. So if someone says, well, I have lumbar stenosis, just trying to figure out whether that's central, lateral recess, foraminal, or extraforaminal, and what's kind of causing that. So something like central stenosis, these patients will have symptoms thought to come from like direct compression, nerve root ischemia, and then also the thought is sometimes increased intrathecal pressure due to narrowing of the canal, with movements like extension, standing, walking. And this can be caused from ligamentum hypertrophy, disc herniation, synovial cysts, stuff like that. And the symptoms of, like Dr. Stewart talked about, with neurogenic claudication, meaning walking, and then getting pain, getting radiculopathy, getting back pain, leg pain, and then it being relieved with certain movements versus differentiating that between something like vascular claudication. There's something like lateral recess, which commonly occurs in conjunction with central stenosis, and that's typically due to facet joint arthropathy, some subarticular ligament hypertrophy, and this typically actually results in compression of the traversing nerve roots going past, versus when we have something like foraminal stenosis, which can be caused by disc height loss, foraminal disc protrusion, synovial cysts, osteophytes. You get compression of the exiting nerve root, so that can be really critical to differentiate between the two, whether you have the nerve root passing by is getting compressed or the nerve root exiting at that level is actually getting compressed. And foraminal stenosis, you'll get unilateral radiculopathy, possible weakness of the corresponding muscles. And then extraforaminal is a little easier. I can really see those discs on MRI, and this causes unilateral compression of the exiting nerve root outside of the foramen. I'm going to talk a little bit about surgical indications, some symptoms, but also just kind of go heavy on the data on why we do surgery, if there provides any benefit. But just talking about the indications in general, we're looking at patients that have undergone conservative management for about 3 to 6 months. They've undergone injections, they've undergone physical therapy, maybe bracing. And these patients are people we start to consider surgery. So first thing that's important is figuring out that the symptoms actually correlate with the imaging, and you're actually identifying the area of the stenosis. And like Dr. Stewart talked about, you can use something like nerve root blocks or epidural steroid injections. I think us typically here, we prefer epidural steroid injections to either obviously provide benefit to our patients, hopefully, but also help with symptom localization. You can also use EMG if you really feel like that's necessary. If it's really not correlating and you feel like it's worthy, you just have to remember that patients absolutely hate EMG. I think that's the number one thing I see in clinic, in Dr. Brooks or Dr. Resnick's clinics, that they they absolutely hate that, undergoing that, even worse than like something like an MRI. And typically these patients, after undergoing conservative management, are having some kind of progressive neurological deterioration, and that can be classified as just they can't walk as far as they could before, they can't live their daily lives, things like that. And these symptoms, Dr. Sewer went over, but these are what you're looking for. So the options that we consider are conventional open decompression via laminectomy or even a hemilaminectomy. Open decompression infusion. We can talk about MIS midline sparing decompression, meaning paramedian incision, Wilty approach, going down your muscle planes and then doing what's called an over-the-top contralateral decompression, removing the lamina. And then something that we're starting to do more here and kind of across the country is endoscopic decompression. Getting into this is where we'll get heavy into the higher level data or lack thereof of surgical versus non-operative management, decompression alone versus decompression infusion, and direct decompression versus indirect decompression. So we'll start a long time ago. The main lumbar spine study was in '96, had about 148 patients. And they showed that surgical decompression actually demonstrated greater improvement than non-surgically treated patients in self-reported back and leg pain in about 1 year. So the surgical group had about a 55% definite improvement compared to a 28% in the non-surgical group. And they found that there were significant improvements in the short form 36 physical function part of the survey at about even 8 to 10 years. So the data was long lasting. One of the bigger trials that surgeons will bring up, talking about surgical versus non-surgical management, is the sports study. And this study actually had several different arms: disc herniation, degenerative spondylosis, and then lumbar spinal stenosis. So this was published in 2008, compared surgical versus non-surgical treatment of just purely isolated lumbar canal stenosis without any spondylolisthesis or instability. And so when we're talking about this, we're talking about mostly central, some lateral recess stenosis. So this is supposed to be a prospective randomized controlled trial with a concurrent observational cohort study. And they enrolled a lot of patients in both sides, but we'll talk about in a little bit. And actually, the waters were a little muddied a little bit with the data. So they looked at short form 36 and modified ODI scores. Their inclusion criteria was a minimum of 12 weeks of neurogenic claudication or radicular leg symptoms. And imaging had to confirm lumbar spinal stenosis, and they were also deemed to be a surgical candidate. So this is how the groups were randomized and kind of the severity of stenosis, which kept things somewhat even as far as mild, moderate, or severe. But none of the patients had quote unquote, spinal instability as deemed by the surgeons in the trial. So the surgical treatment was just standard posterior decompressive laminectomy, except for 6% of the patients underwent instrumented fusion as determined by the surgeon. The non-surgical protocol was physical therapy, and then really just education and counseling with home exercise instruction with some administration of non-steroidals. This study was, the waters were muddied by a high crossover rate and also non-adherence. So 43% of the patients that were assigned to the non-surgical group, they actually underwent surgery within 2 years of the study. And only 67% of the patients randomized to surgery actually received surgery. So to kind of get around this, they broke this down into what we call intention to treat versus as treated analysis. So the top table is the intention to treat. So, who was randomized to surgery, who was randomized to non-surgical management, which they really didn't find a difference based on who they intended to treat. But then they took the randomized group and then the observational cohort and kind of pulled them all together and said what kind of data we could find. And that's what they called the as treated analysis. And they did find a significant difference in the bodily pain, physical function, and ODI scores for the surgical group. So is essentially what I just talked about there, just describing that. So this advantage continued up to 2 years of follow-up. And there have been further follow-up studies that demonstrated benefit at 4 years in the randomized cohort, and then 8 years in the observational cohort. So if you, some of this data, a lot of it comes from, if you just go online and go to the North American Spine Society guidelines, NAS, they classify this as level 2 evidence for surgery versus non-operative management. One of the other arms, they did look at lumbar degenerative spondylosis. Again, symptomatic patients with degenerative spondy, they found improved significantly after surgical intervention at 2 years in their as treated analysis group. So again, patients that actually received surgery versus didn't. They found that patients improve in pain, function, and satisfaction. And surgery here included decompression, but also again, decompression and fusion. So that's the table just demonstrating significant improvement in the bodily pain, physical function, and ODI scores. So a couple other trials that are mentioned in the literature, and then also the NAS guidelines, where a lot of this came from, was that 2007 prospective randomized controlled trial that compared decompression versus medical interventional treatment for just moderate lumbar stenosis. And so this is about a 1 to 2 year follow-up. The key point here is that they found greater improvements with the surgical group with respect to disability, leg and back pain. And they found that surgery remained favorable at 2 years, although the difference actually diminished over time. And then what they did find was that walking ability did not actually differ between the two groups, which is interesting because, as Dr. Stewart talked about, how rehab, our colleagues define improvement as something like walking ability, what we're actually doing, they can have a decrease in pain, but does this actually help them with their daily lives? So NAS classified this as level 2 evidence that surgery should result in improved outcomes. A 2016 study called the Swedish Spinal Stenosis Study was a prospective RCT where patients either underwent decompression alone or decompression plus fusion. So this was taking patients with Pierce spinal stenosis without instability, with and without degenerative spondylosis, and saying, well, we can decompress, but what if we added a fusion? Would that actually improve our patients? So they didn't find any difference in ODI scores or the 6-minute walk test at 2 years between the groups, and this remained similar at 5 years. And fusion in and of itself, decompression and fusion, had longer OR times, higher blood loss, and increased surgical costs. There's just a table breaking down the data. What's kind of significant here is that, again, degenerative spondylosis was not, a primary measure, but because there was such a good mix that they did break it down and classify patients on whether they had it or did not have it. And one thing to note with this is that actually patients that started out with degenerative spondy had a significantly increased satisfaction with their surgery postoperatively, whether they had a fusion or decompression, just compared to if you didn't have degenerative spondylosis. And so the degree of spondy also was not well characterized. The average degree of slip was about 7.4 millimeters. And they did not use flexion extension radiographs to assess stability. They did document that they would look at standing x-rays versus MRI, which we actually do a lot here. One thing to note is that reoperation rate in both groups are pretty similar. Fusion group was 22% versus the decompression alone was 21%. And some of these are infections. I think just under half of the fusion group were infections, and then a little less than that were the infections in the decompression alone group. But a lot of these were either stenoses at adjacent levels, like in the fusion group, or stenosis at the level treated, which happened a lot with the decompression alone group. And then one of the more recent ones was the slip study. So this actually took grade 1 degenerative spondylosis, less than 14 millimeters, with correlative lumbar spinal stenosis, and excluded patients with instability, previous surgery, or mobility. And again, looked, does decompression alone, decompressive laminectomy, or with the posterolateral instrumented fusion, does that improve results? So decompression and fusion was actually associated with significant improvement of physical component scores at 2 to 4 years compared to the decompression alone. This study, again, is also not criticized heavily, but scrutinized a lot. But they, mostly because of the high dropout rate, there were differences in the ODI scores between the two groups, but they weren't significant enough, although they were better than laminectomy plus fusion group. One thing to note, and this has been brought up in other talks, kind of justifying more minimally invasive approaches, that this had a pretty high reoperation rate. So the decompression group had a 34% reoperation rate, which is all for clinical instability at the index level, compared to 14% for the fusion group, which when talking about the study can kind of think about how patients will feel, how they're going to score these surveys, if they feel like they didn't get a good enough surgery or decompression in the first place, and if 34% felt like they needed a reoperation, patients aren't going to be as satisfied. So just something to think about there. And fusion, again, they noted that it was associated with more blood loss, longer operative times compared to decompression alone. And then NAS lists 2 other studies that again look at decompression and fusion for treatment of lumbar stenosis. The one from 1995 is a level 2 evidence that there's no clinical difference between decompression and fusion. And then a 2007 prospective comparative study looked at surgical versus non-surgical and found improvement in pain scores. But some residual symptoms will persist. So they classify that as level 2 evidence. This is a slide on a previous talk I've given, just briefly touching on the data on endoscopic interlaminar decompression versus microsurgical approach. So, as we've advanced in spine surgery, we're looking more toward MIS procedures, minimally invasive. How can we improve patients, their functioning, especially immediately after surgery, but also in the long term? So something like midline sparing, Wiltse approach, laminectomies, and now endoscopic approaches are becoming pretty popular. So this is a study in 2009 that looked at microsurgical decompression versus full endoscopic interlaminar decompression for degenerative lateral recess stenosis, which is critical to note there compared to just pure central stenosis, but still pretty similar. So they found that they had clinically similar results, but the endoscopic group actually had less postoperative pain medication use, quicker discharge, and a sooner return to work, which is pretty big. And the complication rate of the endoscopic group was about 1.2% versus microsurgical was just under 10%. And mean operating time was fairly similar. One other thing to notice with the thought of interbody fusions and if they can provide any benefit for patients like this. So again, when we're talking about this, we're looking at purely degenerative spinal stenosis in stable patients. So, and we're talking about A-lifts, direct laterals, oblique laterals, and then T-lift and pure posterior lumbar interbody fusions. So there's a study not too long ago that was a retrospective review that looked at pure posterior lateral fusion versus PLIFs for stable and unstable spondylolisthesis. And they found no difference in clinical outcomes for the stable group, but in the PLIF side, they had improved disc height. But in the unstable group, there was greater radiological and clinical outcome improvements with the interbody portion of the procedure. So NAS classified this as still insufficient evidence to recommend for or against interbody fusion for stable, low-grade degenerative spondylolisthesis. I thought I'd mention this too, because this is out if you research decompression procedures, interspinous spacers, which is the top right, that's a Coflex implant, and then something called the TOPS procedure, which is the bottom right, which is screws kind of in the facet with a laminectomy, and then what looks like a arthroplasty device, but it's in the posterior aspect. But there's absolutely no data to suggest that patients get any improvement compared to medical or interventional treatment. I mean, obviously to put these in, it still requires a surgery for the most part. So NAS classifies it not recommended. And then just touching briefly, if you can Google this is the most updated one that I could find from 2016. The first general guidelines were written in 2011, and they kind of update them every so often. And this pretty much just touches on what we talked about, that decompression for symptomatic spinal stenosis with low-grade lumbar spondy who have failed the trial of medical interventional treatment. It's a grade C recommendation, which means they could get a benefit. Decompression and fusion for the same surgical patient cohort could improve clinical outcomes compared to decompression alone. Decompression with preservation of midline structures, so midline sparing MIS Wiltse approaches have equivalent outcomes to surgical decompression with fusion. But there's insufficient evidence for indirect decompression with interbody devices for pure symptomatic central lumbar stenosis. So to kind of conclude everything, you know, for patients who have failed non-operative interventional medical management that should strongly consider surgery, that these patients will likely have some kind of benefit with surgery. But this is a discussion with patients. It's figuring out exactly with their symptoms, if this is a central cause, a lateral recess cause, foramen, or all of those, and talking about them about realistic outcomes and expectations. So every patient's different. You know, we'll talk about this with our cases, but you know, there's older, younger, and how they're actually going to respond to surgery and what kind of surgery you offer really depends. And talking to them about, you know, you're not going to be perfect after surgery, no matter what we do. But I think as you do patient selection, but also counseling patients on surgery, I think you'll find that patients are happier post-operatively when you're kind of forthright with them. So that's it.
Okay, in the interest of time, we will kind of speed through this next piece. What's that? Well, we're running a little bit behind, so we're gonna try and get back on track. Great speech, great talks, guys. A little bit shorter for the rest of everybody else, so we have a little more time. That'd be great.
Did you share it?
Not sure.
Let's first share, select that, share. And we gotta swap these guys.
Perfect. Okay. So we do have cases, but just in the interest of time, we will jump forward a little bit and go to the next pathology. Okay. So thank you very much, Michael. Thank you, Dan, for that, for your great talks. And I think one of the big issues with lumbar stenosis is really thinking about durability of treatment, but also patient wishes. So I'll tell you that honestly, I offer to everybody with lumbar stenosis the option for an injection as a treatment option, as well as physical therapy and bracing and things like that, because oddly enough, it works sometimes. And of course, the less they have done to them, the safer they're going to be in their life. So they will always come back to you later on. Yes, go ahead. Do you have the cube? Can we get the cube, please?
I don't think I'm good.
My question was, how do you interpret for injections, like if it didn't work or there was like 30 minutes of maybe relief, like are you counting that as working?
This is a very good question. So first of all, they're given a pain diary. So there's often in the note from the day of the procedure, there's typically a description of what the patient's response was acutely, and then the pain diary gives you a little bit more of a chronic response. My typical management scheme is to have them get the injection, then follow up with me or a member of my team about 6 weeks after the injection was done. I also include physical therapy in that just to make sure that that's all taken care of. That's just my practice. I don't know, Dan, do you do anything differently, or as far as kind of seeing how the response to an injection might work from a lumbar stenosis patient, if you ever do them?
I do injections on the fly, I order injections.
Yeah, right.
I look for the acute response and then the delayed response. I sort of see almost two different things.
Yes, correct.
Now, one's the effect of the anesthetic, the other the effect of the anti-inflammatory.
Right.
And generally a positive anesthetic response is probably more useful for radiculopathy.
Yep.
Positive anti-inflammatory response might be more useful for the lumbar stenosis, but you kind of have to put it in the context of the patient.
Yeah. So we think about most injections are done with lidocaine or bupivacaine or something along those lines, and you guys probably have your own preferences. and then also a steroid. So you have the acute effect, like Dr. Resnick was mentioning, and then the long-term effect. And what we want to figure out, of course, is both. We want to figure out, is that the pain generator? So that's the acute effect usually is what we're really interested in for that, versus therapeutic benefit, which I think of as the steroid side. And so that's where when the patient comes back to see me, I ask them, how did it feel that day? And then how does it feel now? And so if it is the pain generator, but it wasn't a very effective treatment, at least we know that's the spot and it's not a hip or a muscle problem or something else or a joint problem. If it is a longer term or more durable treatment, then I will let them either kind of live with their symptoms as they are and have them either come back with an APP, or even in some cases just go directly over to the rehab side of treatment. So that way they're kind of staying away from the surgeons as long as they can. There's a common line that I say in my clinic is, if you don't want surgery, don't be near me, because that's all I do. And so if I can keep you in a treatment pathway that keeps you away from surgery, then that's the way we should go. Great. Any other comments or thoughts? All right. So now we're going to move on to cervical disc herniation. Again, really trying to think about situations where we may treat this conservatively or with interventions versus surgical. And then we have a couple cases, and if we can get on time, we will discuss the cases. Perfect. Thank you. So we'll start with Dr. Nalini Sehgal. She's our the chair of rehab, is been doing interventions for a very long time, also trained at the Cleveland Clinic. So we have like that kind of combined group. But what is really nice here to some extent, but definitely in other locations, is when you have a lot of collaboration for treatment of spine pain between the interventionalists, the therapists, and the surgeons. I think patients get better care. And so I think that's really great. Thank you very much. Thank you.
Thank you, Dr. Brooks, for inviting me for this talk. I looked at it and I thought this is more for the trainees. So I'm going to bring a more practical perspective to it. And if you do need references, I have those. I have not put them in the slides because I thought it's a 10-minute talk and I can cover only so much. So we'll start with, these are some of the objectives. I'll briefly describe the clinical picture, common causes, and then go over the conservative treatment, focus a little bit more on what I do, which is epidural steroid injections for cervical radicular pain. So when I see patients in clinic, I see their pain diagram before I see the patient. And my patients color their pain diagram, and these are color-coded pain diagrams where every pain quality has a color. So I can look at it and I can say my patient has, this patient has left-sided pain, which is sharp, aching, burning with numbness, tingling, that follows a pattern that's very typical of a C7 dermatomal distribution. This is another patient who has done it where you see the pain traveling along the medial border of the scapula, the medial arm. So one glance at it, it gets me thinking, what's going on? Is this localized pain? Is generalized pain? My next step is to look at their MRI, correlate the clinical picture with the imaging. And if those two match, I know at least what I'm expecting to find on the examination of that patient. Most patients, when they have cervical disc herniation, what happens with disc herniation? It compresses the nerve root. And when it compresses the nerve root and the DRG, which gets inflamed with disc herniation, it causes pain. So there's a compression component, there's an inflammatory component to pain. The pain follows the pattern of the nerve root. So there's a dermatomal distribution to the pain. There could be a myotomal, there could be a sclerotomal distribution to that pain. And there is associated neurologic symptoms in the form of numbness, tingling, weakness. So these symptoms are usually unilateral. And the most common levels, as we know, are C5, 6, C6, 7 levels. But I have seen patients where those who have got fusion at say C5, 6, 6, 7, the adjacent disc now is herniating. So you might end up with a disc herniation at C2, 3, 3, 4 levels, which will not look like this. There will be no radiating upper limb pain, but they will have unilateral neck pain, shoulder pain, sometimes headaches. So it's something to think about. So once I've seen the picture and I've had some idea, I'm going to look at their examination and I'm going to at least check, make sure that the index muscles, the sensory distribution, the reflexes match the picture. So this is what we are looking at, and you can see how it follows the dermatomal distribution, the pain, motor, sensory, and reflex exam. That's the basic exam that you do in the clinic. And so what are we expecting on the imaging? These are cross-sectional views, and I put 2 slides. One is of cervical degenerative spinal stenosis with central canal and foraminal stenosis. And the other one is a disc herniation, which is a soft disc that's impinging on the lateral recess and the exiting nerve root in the neuroforamen. So you see the vertebral artery right here. You see this nerve traversing, and this nerve is getting impinged and probably causing symptoms. So I have to match the findings on the imaging with the clinical findings to say this is a C6 radiculopathy or a C7 or C8, whatever. The most common cause that I see in the clinic and what I read in the literature for radicular pain is degenerative spinal stenosis. And that can present as cervical radiculopathy, or it can present as cervical spondylotic myelopathy. So my next thought is, I need to exclude some diagnoses. So the differential becomes really essential, and the what you have in red is something which I say do not miss, because this is going to be bad for your patients. You don't want to miss myelopathy. So always check those patients for symptoms like numb, clumsy hands, problems with gait, and you find when you examine them, they have upper motor neuron findings. That's a red flag. That's a patient that you need to be assessing and then discussing with your surgical colleagues. Does this person need to be decompressed, or does this person needs to be observed? If the pain is left-sided, make sure that this person, based on the risk factors, does not have a coexisting anginal pain, which you are confusing at cervical radiculopathy. And I had one patient who had like that, whom I asked to see a cardiologist and end up with a treatment for the coronary artery disease. Other thing you don't want to miss is a malignancy, a Penco's tumor, either intraspinal or extraspinal tumors that are mimicking a radiculopathy, and you missed it. So these are some things which we say do not miss ever. The common issues that you have in the clinic is patients can have pain in the neck and shoulder and arm, but they also have shoulder joint issues. And sometimes it's really difficult to tease out which of those 2 pathologies are causing the pain, or they have superimposed myofascial pain. Pain from the infraspinatus can mimic a cervical radicular pain, or they have a coexisting nerve entrapment, like in the carpal tunnel syndrome or an ulnar nerve entrapment. Another common coexisting pathology may be a thoracic outlet syndrome, where the muscles in the neck and the shoulder girdle are compressing the exiting spinal nerve roots, which is the brachial plexus, and creating symptoms. Sometimes you'll see a Parsonage-Turner syndrome, or you may see herpes zoster patients presenting in a similar fashion. So it's essential to make sure before we move on with the treatment, we know what we are trying to treat. So in terms of treatment, the goals of conservative treatment or non-operative treatment is to decrease pain, improve function, improve quality of life, and possible return patients back to work. And the treatment options that are available are medications, which are analgesics, physical therapy approaches, behavioral treatments, and spinal injections. How long will we treat these patients? Depends upon how acute the condition is, what are the neurologic manifestations, and how fast the patient is progressing or is improving. So it can vary from anywhere from 4 weeks to 8 weeks, 6 weeks, 12 weeks, but you have to assess the patient, then decide how long that conservative treatment is going to last, or this patient needs to be seen earlier by the surgeon, and that's critical. In terms of medications, the first line treatments is, because we are talking about anti-inflammation, anti-inflammatories are often first line. Opioids have been considered as first line, and oral steroids. I do not like to use opioids. I like limit opioids. If I have to, I would use tramadol. I do not like to give oral steroids because it's a big dose. And steroids have a lot of other side effects which we would like to avoid. So my go-to medications are, because this is neuropathic pain, is go to neuropathic pain medications. And I usually will prescribe patients duloxetine or gabapentin. And these are FDA recommended medications for neuropathic pain, irrespective whether it's radicular pain, radiculopathy, or some other neuropathic pain. 30% or greater pain relief is considered as significant. So that's what anyone who's saying, I got 30% relief, that's great. You might get up to 50%, but do not keep on pushing the dose higher, but think of something else that you can add to make the pain better. And we have physical therapy treatments, and those physical therapy treatments for the acute stage would be thermal modalities, trial of cervical traction, and a slight neck brace. As the acuity gets better and the patient are able to tolerate, then add the physical therapy exercises, which is a whole host of exercises to improve mobility and stabilize the neck musculature. We do have patients when they have pain, it doesn't exist in isolation. There's an associated psychosocial stress which these patients have, and it's essential to recognize their anxiety, their depression, their catastrophizing or negative coping skills, because those are going to impact your treatment outcomes. And we do look at those in our clinics. And based on that, there are various behavioral therapy options that are available to our patients, and there is good evidence for these treatments to have shown demonstrated reduced pain, reduced anxiety, and improved quality of life. So consider these options for your patients in addition to what you are doing. Now I'm going to focus on cervical epidural steroid injections. That's what we do once we find that this initial conservative treatment is not enough or sufficient to get the patient moving. When it comes to it, the first thing is to look at the images before you do it, and then decide what approach we are going to use. Are there any contraindications, which I've listed over here? What is the medications they are taking, any allergies, and then the drugs that we are going to use. So when the patient is on the table, I need to have a good optimal view. I'm talking about a transforaminal epidural steroid injection. On the left, you see the patient is in an oblique position, but I do not see the foramen real well. I need this foramen to be well visualized. As you see over here, you can see all the foramen, and I know which foramen is stenotic and which foramen I have to go. So if I have to go at 6, 7, this is how stenotic it is. And I need to find a position to place my needle to access this foramen. And the goal is to get the needle positioned posteriorly, the posterior aspect of the foramen. Usually it's in the middle or the lower third. And you see the needle right here. And on the AP view, you want the needle not to cross the midline of the pedicle. You can if you cross the midline of the pedicle and you get at this level, as you see the contrast spreading, this is where the thecal sac is, and you don't want to be entering into the spinal canal. So this is contrast injected, and you see outlining of the nerve root with slight medial and distal spread. The needle is positioned posteriorly. The reason it's positioned posteriorly, as you see in this diagram, is because the vertebral artery is anterior. This is your C6 disc level. There's the spinal cord, the spinal nerve root with the DRG, and there's the spinal nerve. There's a superior articular process, and the needle is positioned posteriorly. We think by positioning the needle posteriorly, we are going to be safe because we are behind the nerve comes between the vertebral artery and the needle, but that's not always true. So we have to make sure there's no vascular spread, and what we are injecting is exclusively around the nerve. And here you see on the plain film with the live fluoro, and this is with a digital subtraction, where what I need to see is exclusively contrast tracking along the nerve and not outlining any other structure. This is another picture of a patient of which I did, and here you see there's contrast tracking along the nerve, that's the needle. But when we did a digital subtraction, you see this kind of a picture. This is vascular, where the contrast is traveling medially. It comes in a very few pulses. It's irregular. It just comes and goes. So this is an arterial injection. You see something like this, pull back your needle, reposition it, and if still getting vascular, abort the procedure. There's no need to pursue or do a procedure unless you're absolutely sure where your needle is and where you're doing is an avascular injection. The reason is, if you don't follow these rules, we can create complications. And there have been, in the past, all kinds of serious neurovascular complications, including strokes and deaths. One of the reasons being is no aspect of the foramen is completely safe. Here you see a picture of a cervical spine and the vertebral arteries in the neuroforamen. And the process was previously the feeding vessels to the spinal cord arise from the vertebral artery and go to the spinal cord at that level. But this is a cadaveric study that demonstrated in cadavers that not only the vertebral artery, but even those arteries that are outside the foramen, the ascending cervical artery and the deep cervical artery, they also give feeding vessels that travel through the foramen on the anterior and the posterior aspect and supplement this vascular supply of the spinal cord. So access to the vasculature of the cord can occur if the needle enters one of these feeding vessels. And that is why it's so essential that we do a digital subtraction and be sure that what the injection is avascular. The other reason for complications is the type of steroid that has been used in the past. We are no longer using suspension steroids like Decompression and Kenalog. They have large particle size up more than 50, which can block an end arteriole and lead to a spinal cord or brain infarct. So these suspension steroids are no longer recommended for spinal injections. We use a soluble steroid, that's dexamethasone. Other recommendations to avoid a catastrophic complication is to use an extension tubing during injection so that there's no further needle movement as you're switching syringes, use digital subtraction, use soluble steroids, and avoid sedation in your patient so that the patient is awake and they can talk and you know what's happening to them. So how much time do I have?
Keep going.
Okay, so this is evidence for intravascular injections. Why should we do a digital subtraction? Isn't aspiration at the hub enough? Well, we do miss a lot if we are just looking at blood being aspirated into the needle hub. Even live injections, there's a high miss rate. And here you see that in one of the studies, in 177 cervical transforaminal epidural steroid injections, 32% were missed by live fluoro, and digital subtraction picked it up. So that's the reason you have to use digital subtraction when we are working on spinal injections. Now, once these results came out, the anesthesiology group was, and a lot of physicians were very scared to do cervical transforaminal epidural steroid injections, and they switched to interlaminar approach. And this is an interlaminar epidural steroid injection where the needle is positioned in the dorsal epidural space and contrast is injected. So you see the contrast injection is going to be in the spinal canal. It can spread wherever it finds its easy access. So it may not go where you want it to go, but it will spread up and down, right and left side. And that works okay if it is bilateral neck pain, but if it's a specific nerve root that you want to target, it's not feasible with this approach. Besides, this is not as safe as folks thought it is. And this is another publication. This is in 2020, where you see a whole bunch of case reports demonstrating as bad or serious complications with interlaminar epidural steroid injections, including paraplegia, Brown-Séquard syndrome, hemiparesis, all of those complications, which we thought only happened with the transforaminal epidural steroid injections. So again, what are the steps that can be taken to prevent these complications? Always review your MRI studies prior to doing the injection. See, is there a viable or visible dorsal epidural space? Limit the volume. Don't give large volumes. Even 2 ml can reach up to C2 level, and you give 3 ml, it might reach up to the brainstem, and patients can have problems breathing. Slow, the speed of injection should be real slow, not fast. That has, for rapid injections have resulted in blindness from retinal hemorrhages. Avoid sedation if possible, and do not inject above C71 levels. So if you follow all those instructions and follow the rules, I think you can go home or go to the union and enjoy a cup of coffee or beer. But you need to be aware of the complications associated with this procedure. What I have not mentioned is cervical radiculopathy patients. Most of those patients, majority get better on their own. That's the natural history. There's a small percentage that are going to progress and require treatment, interventional or surgical. So it's a question of looking at your patient, how they are progressing and how you would manage them.
Thank you.
Thank you.
Thank you very much. Thank you. Have you come up for the cases in a little bit? Okay, Dr. Schmidt joined us in August. He's going to give the surgical side of this. He's also taking referrals for BMI over 40.
Yes.
Yes. Thank you. Yes.
Barb, with the stuff.
Any questions while we're setting up here? Comments? I think that I actually learned how to do injections early on in my practice because the VA lost their interventionalist, and so I worked there for a little while doing injections, and it was very enlightening to see you know, the radiographic images that you really needed to see to stay safe, and also the techniques that you use to stay safe with both digital subtraction angiography and with following the contrast spread. So I think that's really important. I think there's a lot that when you practice, of course, you'll see this more and more and more, but getting yourself in there and seeing those types of things is important. And this was so long ago that we were still talking about this particulate issue, that any steroid that has a particulate in it is quite dangerous to use, generally in injections, but very much so in the cervical spine. So, Brad, thank you very much.
Yeah.
10 minutes.
You got it.
Great.
All right.
Thanks, Sam.
Yeah, so for those that don't know, I'm Brad Schmidt, one of the new spine faculty here. I dabble in all spine, trying to focus mostly on minimally invasive. It's been a great 6 months since starting. I've worked with all the residents. It's been fantastic. Poor Dan has probably taken the brunt of most everything, both figuratively and literally. One of my favorite stories so far this year is Dan and I were struggling to get an inner body in. I had him hold the device, and I took a swing with a mallet, and I whiffed completely and hit him straight in the hand and probably broke a finger and knuckle. So I apologize about that, Dan. So be careful when you want to become a fellow here. So surgical management of cervical spondylosis. So what is cervical spondylosis? We've talked about it already. It's neck pain, radiculopathy, myelopathy, spectrum of issues from deterioration of the osteocartilaginous components of the neck. This can look like a lot of different things. Here's a patient who would come in with more myelopathic, hyperreflexia, balance issues, lateral hand issues. Here's a patient who comes in with likely left arm pain solely and really no other issues, maybe a little bit of neck pain. Here's a patient who comes in with neck pain and some hyperreflexia and some mild balance issues. It's been going on for a long time. Here's a patient that has a lot of swallowing issues, right? So you have all these different spectrum of things that can happen in the cervical spine. So the question is, what the heck do you do about this, right? Well, from a surgical standpoint, there are guidelines. How nice is that? And you can see the senior author on this one payment. We are graced with his presence in this room here, Dr. Resnick. So, but the summary for this, though, is that the answer is there's a lot of ways you can treat this that are successful. Okay, I mean, that's the moral of the story. There's front, there's back, and there's variations of that. Real quick, running through the guidelines because it's important we talk about this. You can find these specifically on the CNS website, but real quick, ACDF versus corpectomy, this is multi-level ACDF. Equivalent fusion rates if you use a plate and screws. If you don't use a plate and screws, fusion's better in the corpectomy group. However, there is higher rate of graft kick-out issues, things like that. ACDF versus laminectomy. Both are produce comparable improvements, but if you're doing a short segment, try to do the ACDF because you then limit that the issue with potential kyphosis after a laminectomy. ACDF versus lamina fusion, pretty equivocal. ACDF or corpectomy versus laminoplasty, fairly equivocal. Laminectomy versus laminoplasty, equivocal usually on the outcomes, but if you have issues, if you have concerns with stability, again, laminoplasty maybe should be considered because of the potential risk again of the kyphosis with laminectomy alone. And then laminectomy versus lamina fusion, it's the exact same story. It produces usually same neurologic outcomes. However, if stability is a concern, would err towards lamina fusion because of the same issue with the kyphosis. And then laminoplasty versus lamina fusion, roughly equivocal. So that's a very quick pan through the guidelines. So the first starts is how do you want to approach it? You're going to go front, you're going to go back. You can do discectomy, fusion, arthroplasty, corpectomy, all from the front. There's technically a phragmotomy from the front as well. It's fallen a little out of favor, but I'm sure some people are still doing it. Posteriorly, phragmotomies, laminectomies, laminoplasties, lamina fusions. Lots of different surgeries we can do, right? So how do you hammer some of these things home? Well, foraminotomies are a great option. I showed that one case with that unilateral disc herniation off to the left side. Are potentially a great option. You can get a resolution in radiculopathy pain in about 95% of patients, and really no change in segmental kyphosis. Some studies have been done, and so as a subset of that, there are foraminotomies you can do open, you can do MIS through a tube, you can do MIS through endoscopic, and people have looked at this as well too. And so the things I've underlined in red are showing the improvements, hypothetically, with the MIS versus endoscopic foraminotomy versus open foraminotomy, decreased blood loss, decreased operative length, and a decreased length of stay. We always talk about how much joint can you take off, right, with the foraminotomy. It's about 50%, and that was Dr. Zeblik did that, and that's the bottom paper here. I just highlighted that in case people want to know that. Laminectomy with and without fusion, right? So both produce, like I said, similar outcomes. However, the laminectomy with fusion, hopefully then is not associated with the late deformity. And talking about that, so studies have shown about 21 to about 38% of kyphosis post-cervical laminectomy. So it is a real problem. This paper, however, says, okay, so about 47% of patients did progress to kyphotic deformity. However, none of these resulted in any neurologic deficit, right? So that's the key, right? So you may radiographically get some kyphotic change with laminectomy alone, but is it clinically important? That's the big question, and that's very much so patient dependent and situation dependent. Laminoplasty. Laminoplasty is a great option if you're trying to not fuse someone, to avoid some of that adjacent segment disease issues. However, the one thing I wanted to bring up with this study, we all think in res things that if you want to preserve motion, do a laminoplasty. You lose more motion with laminoplasty than I think it gets credit for. And this was shown in this paper as well too. They actually demonstrated a 50% decreased range of motion. Now that's still better than probably the 100% decrease you get with a fusion, right? But it's not without like a loss, all right? So I just want to make sure the residents and others know that, right? That a laminoplasty, hopefully you preserve some motion, but it's not the same as a laminectomy. A laminectomy alone, you would hypothetically preserve more motion than a laminoplasty. Great paper out of the Red Journal, which just shows that laminoplasty is a great option for improvement in neck pain, interscapular pain, radicular arm pain. And again, they showed that you do preserve range of motion. Again, 75% loss of range of motion with fusion versus 20% in the laminoplasty group, right? So on the spectrum of range of motion preservation, lami alone is best, laminoplasty in the middle, and then lami fusion clearly at the end. ACDF. ACDFs are anterior cervical discectomy infusions, things we do very frequently. One of my favorite surgeries. Patients are a lot happier with it. It's a lot less painful. They seem to recover a lot better. Minimal scars. They have good outcomes. This has been known for a while. This is just showing improvement in VAS and ODI, even up to 10 years with ACDFs over time. Adjacent segment disease, though, is a really important thing we talk about with any surgery, right? In low back, mid back, or even cervical spine, but it really seems to come up with ACDFs. And so that's about 3% roughly per year risk of adjacent segment disease. And it does correlate with the motion segment. So it's highest at C4, 5, 5, 6, and C6, 7. That's the chart on your right. And those correlate with the more, the areas of higher degrees of motion, right? So the more motion there's going to be in those levels, the higher the rate of degeneration is likely going to happen, right? That just inherently makes sense. It's physics, as one of our colleagues would say. Do you need to use plate and screws with ACDFs? Technically, you don't, but some studies have shown, and this is a meta-analysis here that shows that it does improve fusion rate and lack of subsidence. And so this is showing that your odds ratio is statistically significantly improved with fusion rate and decrease, again, statistically significant with subsidence with a plate and screws rather than just graft alone. And dysphagia is equivalent, which is good. And the equivalency also goes to NDI and VAS scores as well too. Arthroplasty. Arthroplasty is controversial as far as data goes. I think there's definitely a role for it in my personal opinion. There are studies that do show that arthroplasty is at least not inferior to anterior cervical discectomy infusion. It really comes down to patient selection, patient population, and making sure patient selection is really, really key. The graft has to fit perfectly. The disc space has to be well preserved and so forth. The hard part with the data aspect is a lot of these studies were industry driven. And so you have to take sort of all these things with a grain of salt. But again, it does seem to show that things are non-inferior. That was a whirlwind. I think I kept that to roughly 10 minutes. But the point is there's a lot of different surgeries you can do for cervical disc disease. It really comes down to how do you want to approach it as step. Number one, do they need surgery? Then how do you want to approach it? Front, back, and then it really branches from there. And again, per the guidelines, the answer is there's a lot of good answers. Whirlwind, questions?
No, that's great. Thank you. Thank you. So if you come down, we're gonna get you guys up here for the panel. Yeah.
You want the intro one back up?
Yeah, if you can get mine back. Any questions while we're getting set up? Any comments? Get myself to the right spot. What's that?
Swap.
Don't forget the cube.
All right. So I'm one of the pain medicine fellows. I think one thing I want to try and leave here with is a more clear idea of who definitely deserves a surgical referral, who probably doesn't. And there's probably a lot of gray in the middle there. Obviously, if there's neurologic deficits, get MRI and going your way. If there's kind of neck pain, but no specific neurologic symptoms, my inclination would be, we'll try some stuff first. If they're still not getting better, send them to you. Could you maybe clarify some of that gray in the middle of who you would recommend surgical evaluation sooner rather than later?
Yeah, that's a great question. Is really one of the $1 million questions for any sort of referral patterns. Really, from my standpoint, I think you're exactly right. If there's a true sense of radiculopathy or a true sense of neurologic weakness, then absolutely a referral, I think, is wholeheartedly appropriate. The neck pain on the other end of the spectrum, like you implied, is very tricky. Neck pain is extremely challenging to treat surgically. In fact, I every once in a while you'll get a patient, and I'll get a patient in my clinic that was billed as having something down the arm, but it's purely neck pain, right? And they're always frustrated when I tell them, listen, there's really nothing I can do unless there's a gross instability or gross deformity, which absolutely can happen. Then surgery for neck pain alone is usually, in my opinion, not really indicated. Again, unless there's a true instability that we can see on imaging. That gray area is tough. If there's any concern, other tests like EMGs, nerve conduction studies like that, things can be useful as well too. Because sometimes if there's some clinical equipoise, that can help sort of differentiate some of these things and add more fuel to the fire, to help with that decision making. And so I'll even order those too myself, as if I have any question diagnostically, by the time they get to me. Otherwise, it's tough. If there's any concern at all, I mean, I'm new to my practice, so I'm kind of in the mindset of I'm trying to see more people than not anyway. And it's always easier to have the conversation too. It's like, even the neck pain people, right? I think a lot of times they're still happy to at least have met someone, whether it's a surgeon or the ortho rehab. I think they're happy to at least talk to people, to talk about the problem, to at least have a better sense of what's going on. So, again, being young and fresh into this, I'm never mad about still seeing those patients, because it's still sort of establishing me in what I'm doing. But I'm sure Dr. Brooks and Dr. Resnick are a little less excited to see those patients. But
I don't want to give you the impression we get mad. That's not exactly what happens. But because we have a limited amount of clinic space, we're trying to keep the surgery ones in the clinic space so that there's shorter lines for those patients. But I think what you're what I think often drives this is really how comfortable are you with looking at the films and understanding what's being compressed, and that's really critical from the non-surgeon side. The surgeons are like very confident in looking at these films and saying, that's a nerve root. Does the nerve root fit with what the symptoms are? And then saying, can we be conservative or not about this? We're just because we spent so much of our career looking at films. If you're not that confident, that may be the point where you're would be a little less, have a little less understanding of, okay, this one really needs to see a surgeon first, or at least have a discussion with a surgeon first, that's reviewing the films and say, this one looks a little bit more dangerous or a little bit more like it's not going to get better with an injection kind of thing. And let's just see this first. Okay. And what Brad's driving at, of course, is what's the collaborative relationship you have, because these are two somewhat separate fields. Dan, if you don't mind. Cube. Yeah.
So, cool.
You just have to sit close to or talk close to it. Yeah.
So realistically, referrals from pain rehab, that's not a problem for us. If you think that they need to see one of us, just send them and we'll see them. The problems that we have with the triage are from the primary care community, where someone comes in, they've had a scan, they got something, and they've had nothing done. There's no exam on the chart. We have no idea what's going on with this patient, and trying to triage those. Those are the issues. We used to have a course here where we used to teach this stuff, but in the evolution of the curriculum, it got canned. So now, on a typical day of call, 2/3 of our calls will be on the primary care management of acute low back and low back pain and radiculopathy. So if you have a funny feeling about someone, just go ahead and send them, because you're already you're already the echelon above core here, and so I would not hesitate to just send it on if you have a funny feeling. And whenever I see Jim's name on a referral, I just accept it, because he's done the work, and that's usually a chip shot for us at this point.
Right. So first case here, we've got a 60-year-old with a cervical disc herniation, concordant left-sided C6 radiculopathy. It's been going on for about 6 weeks. She did do physical therapy. She has a little bit of numbness and C6 dermatome, no real weakness, but she definitely has pain. You guys both have different perspectives on this, but I definitely think this is a gray area one. So
How cute is this?
it's about 6 weeks.
So, and has she had any treatment so far?
Just the physical therapy.
Okay, so I would, considering this is a disc herniation, it's impinging on the C6 nerve root, and you said there are sensory abnormalities, but no motor or reflex deficits or any other.
Correct.
issues.
Yeah. So it's a very much a pain phenomena, not a motor or a true sensory
And you see on
problem.
the sagittal view, the spinal cord signal looks okay. There's a little bit of decreased CSF signal interiorly where the disc is, but it's not compressing the cord. There are no upper motor neuron signs to worry about, nothing on the thing.
Yep.
Treat it conservatively. I'll start with anti-inflammatories unless there's a contraindication to it. And if there are neurologic, findings, since there is sensory deficit, I would add duloxetine or pregabalin and give her a trial for at least a few weeks. But if the pain is severe, she's not moving, she's really disabled, then I'll go ahead and do a C6 nerve root block on her, transforaminal.
Yeah. Transfer.
Combine it with physical therapy and have the patient move on.
Yeah. Okay. So Brad, now same scenario. So it hasn't got any additional treatment. In your clinic as a surgeon.
Yeah. So this is actually, I think, a pretty good representative, of kind of what you were just asking about, right? So this is someone that I would still see in clinic. Then now, that's not saying I'm going to offer them surgery right away, but I would see this, right? So this is someone who, at 6 weeks, there's a clear problem, and it's a C6 radiculopathy on exam. It's sort of a slam dunk, right? But at 6 weeks, in the absence of, I would like to see them. I would have this conversation with them, be like, listen, surgery very well may be in your future, but I would actually still recommend trying conservative management at this point first. 6 weeks is, in my opinion, on the short end of what an acute radiculopathy can potentially get better from. So if they're on board with it and willing for, I agree, anti-inflammatories, continued physical therapy. I probably wouldn't push an injection at this point just yet, and just kind of see how it plays out. But again, have the conversation, like, listen, you have a real problem. We can see it there. If this persists or gets worse, then, I can even, a lot of times I'll even talk to them, what surgery may be an option, just so that way they have that sense of where things could go. But yeah.
Yeah. So I think this kind of is like that gray area. And I will also tell, everybody, we are extremely conservative here because we get so many referrals. that we tend to be much more on the end of what's right for the patient as opposed to what's right for our pocketbook. And so that can come into play though in other referral patterns. So depending on where you end up working, it can be anytime you send something to a surgeon, they're getting an operation. So that has to be, you have to learn those things and get a better feel for what that's going to be, so that they don't end up getting something that you don't think is necessarily the right thing for them, right? And this is a good example. Any other comments about that case?
And I think majority of these patients recover.
I fully agree, and I think the other thing is, a lot of the studies, such as sports study, really demonstrated that it's just a matter of time, and so it depends on how miserable they are. If they're not too terribly miserable, they can still recover. The MRI scans tend to become an anchor, a psychological anchor, and that can be something you have to really talk through the patients and need other providers with them about. That is that they say, oh, there's this thing here. It says it on the report. There's a disc pinching the nerves. That's got to come out, and you have to kind of explain that actually just because we see it, the way your symptoms are doesn't always require that, and that takes a little bit of talk time, but it is helpful.
Yeah, it's funny you say that, 'cause I don't know if radiologists really know the power they have on patients.
Right.
It's funny, like if it's written in that report and they read it on my chart, they will hang on every word of that. I'm not even joking. And so a lot of times, if you're like, oh, I have this huge disc, we got to. Sometimes a lot of clinic is spent sort of talking them down, honestly. So, and that's not to besmirch any radiology or anything like that, but I mean, patients really hang on every word.
I think that's where, because they get fixated, they get anxious,
Yeah.
and that anxiety drives a lot of the treatment.
Yes, exactly.
Correct.
Yeah.
So you have to talk to them. You have to tell them that this is a natural history of the disease. It's going to get better. But some patients are too anxious. Then if they're too anxious, then I'll send them your way so that you can convince them that surgery is not needed.
Right.
Go ahead, please.
So in this
you.
situation, they're just coming in with like 6 weeks, which is pretty short amount of time, with just, it sounds like, pain. What if they also had maybe a little bit of like weakness too? Are you still going to be that conservative?
So I don't get too worried when they're 5- 4+. When they start to get less than that and it's really easy to break their strength, then you just have that discussion with them about, and if it comes along with pain, of course, that's a even better indication. But I don't, it's right around the 4- to 3s where you start to say, oh, you just get surgery, just do it. And I don't know what your breaking point is, Dan. There's no real literature on this, but that's kind of where yeah.
You're not on a 3, you're not.
Yep.
They're just funny grabbing that.
Yeah.
You're gonna offer that, but
yeah.
I've seen people with Greece get better.
Absolutely. Right.
You talk to the patient. I would tell them that the chance of motor recovery is probably enhanced by decompressing earlier rather than later, but it's not absolute. And some people want surgery today, and some people never want surgery.
Yeah. That's it. That's exactly right. This is actually, from the resident's perspective, why being in clinic is so valuable, because you end up seeing this situation. You know exactly what surgery to do to it, but you just don't know when to do it, and that's or not to do it, and that's really critical. Next case is now a 45-year-old woman with a cervical disc herniation. Again, we got the C5-6 level, but you can see that there's central stenosis, a little bit of cord signal change, just has radiculopathy, but no myelopathy. So
this is a situation which cervical radiculopathy with, you're seeing cord signal changes and central stenosis. This is a patient that's likely to progress.
Mm-hmm.
And develop myelopathic symptoms if they have not developed. So yes, I will start with conservative treatment, but I'll be extremely vigilant, monitor the neurologic status, and at least consult the surgeon on this one. I'm not going to be sitting on it.
Yeah. The thing I'd say with this, again, another patient I'd see in clinic for sure. the two things I want to bring up is one, remember that we've talked about this very recently, that the guidelines say that when you have this type of phenomenon, radiculopathy can be considered early on the spectrum for myelopathy. That's actually per the guidelines. So this could actually be sort of a myelopathy, right? Don't lose sight of that. But number two, the guidelines also say that a young, healthy individual with very early myelopathy is unlikely to progress over time. And so counseling them about that and still having that conversation about giving it some time isn't necessarily the wrong thing here. Okay. And so again, another thing to bring up.
So that there is symptomatic or asymptomatic myelopathy. That's the difference. If they don't have upper motor neuron signs, they only have this radiologic findings versus someone who has positive upper motor neuron signs.
So if they do,
My mind is a continuum.
Is exactly, that's exactly.
It's a continuum, but I would say when you see something like this and they definitively have upper motor neuron signs, that's in our world, it's going to be easy.
Yeah, that's
you're going to do surgery.
Exactly. Yep. Exactly.
And when you see cord signal change, you're much more likely to do surgery. At least I am. But then if you see stenosis but no cord signal change and some radiculopathy, I kind of have this discussion with the patients.
Right.
Well, maybe this is on the continuum, and again, high price real estate. So it's worth considering. But when I get asymptomatic stenosis, that's when I really have to have that discussion about where things are going to go.
And I would kind of follow these patients up more closely because over time, the natural histories, they are going to, good number of them will progress.
It's funny. So that's the hardest one for me, which is I was not on here. It's sort of the asymptomatic stenosis, right? You'll triage a patient just on Epic, and their spine looks horrible, and it's you see them because it was billed as something, and then you see them in clinic and they're completely asymptomatic, no upper motor neuron, no radiculopathy. Now they're just neck pain, but they're but it's tight the entire way. It's like. That's the hard one. Obviously, you're not going to.
My concern over there is when patients don't have that, but they have gait problems. Their balance is.
Yeah.
Right. I'm worried that this person falls, ends up with a spinal cord.
Exactly.
Injury.
Yep. Exactly.
So that's where my concern comes with that population.
Absolutely.
It is that these are the bigger challenges. But then, of course, if you go along that continuum and you say everybody with stenosis that's older needs spine surgery, there's a lot of risks associated with the surgery part, and suddenly it becomes dangerous again. Go ahead.
Yeah, I think this again is you have to look at the patient in front of you. So if this is a healthy 45-year-old with radiculopathy in that scan, I'd be pro operation on this person. I would see this as part of the myelopathy spectrum based upon the guideline that Brad talked about. Yesterday in clinic, I saw a patient who had a huge calcified disc at C2-3, which is causing severe cord compression. This was picked up because he had ear pain and got a CT scan of his head that happened to show this calcified disc at C2-3. He's completely asymptomatic, with the exception of possibly mild gait disturbance. If that patient was a young, healthy person, I would probably operate that patient. This guy was 78, 430 pounds. The morbidity of the operation is greater than the morbidity of having that disc in his neck. So it depends upon there is no one rule for everybody.
That's right.
There's not one operation per scan type thing.
Yeah, and that's critical. Although, again, this junior partner over here is taking large BMI
I'd be happy to
patients.
see them for.
Yes.
Continue and follow up in 6 months.
But I think the other thing you raised is how do you follow them up? And so I typically have done annual follow-ups for probably 2 or 3 years. And then over time they get to know me, I get to know them. We get to talk about what the symptoms might be like, just make sure we're not missing something, and then kind of let them follow up on an as needed basis in the future. I don't think that's perfect. I know other providers who will do continuous follow up for life, or just eventually operate on them. So that's a tough one. Yeah, for these severe stenosis. I do not want to torture everyone's bladder, so we're going to take a break for 10 minutes and then come back. I'm good. Thanks, Brad. That was great.
Did 1,000, 100 patients. 3 to 7 years period, 6 to 7 years. This person has a vision. So if they happen to go up with they can get still they have an idea. Even though they have pneumopathetic signs on examination. They have to go out of the group, so they have knowledge.
Yeah.
So that you know, one of the aggravating things when you're training is you're looking for the answer.
I know. I like having.
So the guidelines tell us in terms of framing the questions, right? But sometimes people don't fit exactly inside the boxes that the guidelines.
I might send you an updated one over actually.
Okay, I'll wait then.
Okay, well, let me just see if,
Yeah,
I don't know, I may just go ahead and leave the one I've got.
Stenosis and radiculopathy.
I want to throw a picture in, but I don't know what I'm actually.
Yes, sir.
The ability to.
I'll leave it off.
We've got time, that's fine.
I'll keep that in mind.
This one just happens. I have a whole talk on the I don't want. He's missing. When we don't have them. Okay. Yeah.
Was it? Oh, yes, there's the board, there's the board. Yeah, no, that's how it comes up. That's how we use it. So, yeah, so when you make a case, and the reviewer, like, you go through it and basically decide whether they're I should read my guide the other Saturday. How tough was it that many the guy or the lady? What I do? He did Q1 mini tumors. Well, that was pretty. Was that intradural? It was intradural extramedullary. Okay. It was a big tumor. Yeah. But it had done all the work for us. And so it pushed the cord over slowly over time. So the cord, so once we started to undercut the tumor, we had room to work. So yeah, so that's fascinating. Yeah, it made it easy. I still remember what Mary was big. I wasn't sure which one you were talking about. No, I saw getting clear. No, he did great. Yeah, and his pathology is great one. And we supposed to have some last ones. That's good. Nice work, man. Keep sending them. Find those. I'll do those all day.
Okay, Dr. Leonard, you ready? No, you're not keeping me. I wanted to give you plenty of time to hobnob. So I like seeing that. We are going to talk the next discussion topic is going to be degenerative scoliosis, which is a very common problem, becoming more common as we're seeing more change in demographics, both in the U.S. and globally, that the population is aging, and so degenerative disease and degenerative scoliosis is becoming a more common thing to see. I think there's a lot of challenge in what the treatment options are. So I'm very excited to have Dr. Leonard here with us, who's been treating all these conditions forever and doing a great job of it. It's going to talk to us about what options we might have for the conservative side. And then we'll talk about surgery, and then we'll talk some cases. Thank you very much, Dr. Leonard.
Thank you.
Awesome. I gotta share this. And then this. Switch. That should go away. Okay.
Awesome. Thank you. Dr. Brooks, thank you for having me. I think this is wonderful. We're doing the integrated program here. So I've been delighted to be involved in the spine clinic since its inception in '89. And it has been wonderful to see the interaction, quite frankly, between orthopedics and neurosurgery. They don't come with guns. They don't shoot and hit themselves, hit each other. And so it's worked out quite well. This goes back, I think, the credibility for your program. You got to go way back to Manuka Javid, who just died last year, 101, 2 years ago. Yeah. I've started out with him here, and, he was so enthusiastic about the spine. I was blown over by how incredible thorough he was on the consults. And your colleagues now have taken that to a whole new level. With Dr. Trost being part of the initial group in the spine clinic, Dr. Resnick joining, and now Dr. Brooks doing an excellent job here, and Dr. Schmidt with us now. We appreciate that. So it's worked well with orthopedics, and there's plenty of work for all. I think I need to know what neurosurgery knows as far as not so much all the technical aspects, but I need to know how you approach problems so I know who's a good referral for you. It's kind of nice to know the personalities. For instance, if they swear a lot, send them to Trost, and that works pretty well. No, I'm kidding. Greg's a great guy. But I need to know where you're going to go with things. And I think that's the program also does. I think that's epitomized in how our screening process has worked out well over time. There's an incredible individual that does the screening process, actually a medical assistant, but she is actually brilliant. So that has helped a lot. And I think we in rehab and in pain have been quite selective as far as the cases we would send to neurosurgery also. So if you look at it, when you hear that the new patients that you guys see, I mean, about 40% go to surgery approximately compared to other facilities where it's a much lower level. That's pretty phenomenal. So I hope that indicates we're doing a good job in rehab and we're sending appropriate referrals. So my job briefly here is who am I and what do I do and what does it mean to you? So I look at all the non-operative approaches, just as Dr. Sewer and Dr. Segal have well expressed earlier. And I'm in the clinic a great deal of time. And so I'm going to optimize them out, but also I have to look at the patient's psyche and know where they're going to come from on this. And when I see a patient, you know, after I work them a while, we work them up. I usually get to the point and say, look, we usually got about 3 choices we can do. You know, you can continue doing what you're doing on your own. We can start doing the interventional type of work, or you can talk to the surgeon if it's bad enough to do that. And it's interesting, only about 50% really want to go on to surgery. So it's really incredibly small. The older they are, the less likely they are to do it. So I think having the patient involved in that decision process and giving them the option really gives you a much better outcome as far as who's going to pick what they feel is best for themselves, with the exception of a few personality disorder type of cases that may come through or other issues, but the majority of the time it works pretty well. This one had a big impression on me. This goes back to about 88, 89. This was a 16-year-old from Upper Peninsula, and she has spinal muscular atrophy. So she came in, the view on your right would be a picture taken in the summer of 89. She had most of her weakness, of course, was in her trunk, and she was standing with flexed about 20 degrees. Didn't really have any pain. Came back 6 months later, had films, and it's gone to about 23 degrees now. Came back another 6 months later, and it was really quite a substantial change in it. So this showed me how important the muscular group is to try to maintain control of the spine, and how we really need to rehab them as much as possible. She ended up going on to upper thoracic to lumbar fusion with good Dr. David Mann, who was a pediatric orthopedist who was retired quite a while, but she really turned out quite well. But it was really impressive once that curve started going, how quickly it went. So it seemed like a well-balanced curve, but the lack of muscular control really made a difference. So obviously we're going to talk about scoliosis, but you can't ignore the fact there may be a kyphotic type of issue going on. This individual is in their, I believe, their late 50s. You can see the wedging of the vertebrae here with a Scheuermann's kyphosis. And the big concern was their head was down, they're looking into the floor, and so they wanted to get that fixed. And so it's a major issue. This was a fixed deformity. Once it's been there about a year, you're really not going to be able to stretch out the tissues that much. Along with that, on the right side here, we do have the scoliosis. So we had to take both into account. Yes, we tried the braces. Yes, we tried other options. And eventually they ended up having a surgical approach to this at another institution. So I don't have the films, but looking at the three-dimensional aspect certainly is a major issue. Now, these are more typical what I see. This individual, she's about 80 years old, very active, very dynamic lady, 2 years in the Peace Corps in Sierra Leone, has an active life in teaching. Now her biggest issue is not pain. She cannot function. She can only walk a short distance. When you stand and look at her, you can see that she obviously has a list to the left here. Not only that, if you look at 3 on 4, there's a lateral listhesis occurring. I frequently see on these individuals, that it's more of a lateral listhesis and an increase in the curve that starts to arise as they get to a certain point. What was interesting is that her main complaint was pain over the iliac crest. And lo and behold, her ribs were hitting down on the iliac crest. So the main treatment was actually a corset to take the ribs off the iliac crest and relieve the pressure. And it improved her walking, probably able to walk about 3 times what she was able to. She still had somewhat of a limp. Obviously, you want to check when you get this much of a curve, you'll start getting degenerative changes of the sacroiliac joint. You may start getting degenerative changes of the hip, and I think we're going to address that in one of our case studies later on. So clearly we want to look at the spine. We want to look at intrinsic aspects on the spine. Most of my day is spent looking for pain generators, a specific nerve root, a spinal stenosis, a compression fracture, spondylosis with instability. This is the scoliosis group. That's a different story. You got to look more globally. It's going to be more than one level. And then if you're looking at your surgical approach, obviously you have to say, well, you know, how many levels do you have to use to stabilize it? And I'll defer to Dr. Brooks on that. The other issue is, a lot of times there gets a lot of soft tissue compression. This next individual, let me go back to this. I'll show you that one later. But anyway, here it would be compression on the abdomen. They'll start getting GI problems because they're getting kyphotic, and then you start getting irritation just because of that aspect of it. So what's our goals? We'll try to look directly on work directly in the spine to work on the exercise approaches. A really good physical therapist that would have a big impact on this, just to get them on a program. We try to compensate the stressors with the extrinsic devices such as braces, canes, or walkers. There's a new type of walker that actually makes someone walk more upright because the handles are up here. It's kind of worked well, but it's a good concept, but it doesn't really work for everybody. And then if we find a specific pain generator, we're going to treat that. Not only do we have the groups that are too stiff, Dr. Rudin here has an Ehlers-Danlos clinics for the hypermobile, and it's so popular that he's backlogged for years getting into that. So it's an issue here, and especially if you're looking at the surgical aspect, when you have a genetically related connective tissue disorder. I've seen surgical cases where it was a beautiful surgery, and then the next two levels up started going. It was a C3 to C7 fusion, and then C2 subluxed on C3. So it's a real contemplative call that has to be made on those. Of course, obviously, if there's neurodeficit, it makes a difference. But the majority of patients we see are hypomobile, and we'll work on that. We'll try to balance that out as far as a strength, a flexibility type issue. And then also look at the adjacent joints to see how much a factor it is. What are the tools at our disposals? Of all things that work, over time, you go back to the Quebec Task Force study in 1987 through the present, the most important exercise is aerobic exercise. So you got to get people moving. My thought is the most compliance I get is people doing a walking program. If they're not doing well, I have them use a cane. If it's one side of pain, it takes about a third of the weight off that side. If they're having balance issues, I'll have them use a walker. If they really can't walk very far and they have to sit down because flexion relieves the stenosis in the canal and foramen, the recumbent bike is excellent as long as their knees and hips will tolerate it. The new step machine where you're sitting and you do the opposite arm, opposite leg motions on it is the most popular machine in health clubs for the geriatric set. So those type of things work very, very well. As Dr. Sewer was talking about earlier, we always got to balance that out. Is it neurogenic claudication or vascular claudication? And so more frequently than I have in the past, I'm sending them for vascular studies just to see if we can improve blood flow to that aspect to make a difference. Along with that, if there's a neuropathy affecting the balance, we got to compensate for that. We're blessed with having a warm water pool. It's up to about 92 degrees in both the east and west side clinic. It's the most popular resource in it. A lot of people don't like to get in the pool, but if you get up to about chest deep water, you can get 75% of the weight off. They can really do a whole lot more. Core strengthening is good, but the caution, if they have more than a few exercises, people won't follow up on them. If there's a balance issue, Tai Chi is actually the best to work on coordination and balance to learn how to compensate for a neuropathy that would be present. As far as basic exercises, Stuart McGill out of McMaster University in Toronto came out with some very basic approaches that I listed here. Those include the knee to the chest. Sorry, we're a low budget, bad model. The single and double knee to chest is excellent. And also if the single knee to chest, you'll stretch out your hip flexors that will make a difference. The hip rotation is good for limbering up in the morning and just to get the mobility in both the hips and the back. They can do these on the bed at home. The prone extension, here, look at here, I was a student for too long. Look, I have no extension in my spine. So trying to restore some of that, even if there's a little bit of pain, can make quite a difference. But many times the kyphosis or the flexion or deformity or tightness in the hip flexors has been there so long, you really can't stretch them out. Actually, the lateral plank, where you strengthen the quadratus lumborum, going from the spine down to the iliac crest laterally, is more of a stabilizer of the spine than the abdominals. I have a lot of patients that really get flared up when they try to do sit-ups, or they crunch real hard, they try to jerk, and it really doesn't give them that much strength along the way. So doing the lateral plank, initially doing it from the knee level, after they're better at it, going from the ankle level, holding that for a minute. That's a strenuous exercise. Try it yourself. I think that's good for spine surgeons. This is a good example of someone that had a Chiari. They had a tethered cord, and they had congenital absence of ribs on the right side. And the other case I tend to see this in, I see a lot of individuals that had a Wilms tumor as a child, had radiation, and they had the same type of picture, very localized scoliosis in the lower thoracic upper lumbar spine. I find these are a really difficult group. I actually encourage this one to talk to the spine surgeon. She had social issues, so it never really got done. But her, in case she had more of a restrictive type of lung disease, and occasionally I'll send people for pulmonary function studies, but usually that's done more pre-surgical because it doesn't make a great difference as far as affecting what I do. Doctor, I won't go on into this much, but the braces, the best brace is the one that the patient will wear. And if it gives them relief, if it doesn't give them relief, it's really not worth doing. I never get the rigid braces, the turtle shell ones. They're way too uncomfortable. The best is the old style corset with the strings on the side, the Velcro, on the wraps to give a further tightness, and the metal supports and the posterior aspect. That's the one that Grandma wore, that they're more familiar with wearing, and they can double their walking distance by having something like that on, or just be much more functional. Many individuals will have abdominal weakness. The unique group is women that have had children and have had a rectus diastasis. They just don't do that well with strengthening. The therapists do a nice job, do an ultrasound guided exercise to them to re-educate the abdominals, but it still is difficult for them to build that up, and they end up having long-term weakness on them. If you look at the sports medicine literature, if you want people to be active, the real goal is you got to restore the range of motion of the spine. In this cases, we'll have fixed deformities with scoliosis that are really hard to have a big impact on. The strengthening, I get much more good out of strengthening the major muscle groups of the lower extremities, the quads, the hip muscles, the upper body, doing the deltoids, the lats. One study did that, and they actually had better results than a lot of others as far as long-term relief. Getting the endurance back, that's the last to come back. It takes a long time for someone to build up endurance after they've been down for quite a while. The neuromuscular coordination, especially we're getting the elderly, is a lifelong issue. And getting their functional abilities, you know, do they feel better or do they function better? That was the rub on doing narcotics, is that people may feel better, but they really don't do a whole lot more, and they never return to work, rarely return to work even when they're on them. So there's a lot of modalities. There's about 200 modalities listed in literature for spinal disorders. If you use heat on the back, the optimal time is about a half hour at a time. Otherwise, we see these people come in with the skin burns. It really doesn't do all that much for them. If it's radicular type pain, the TENS unit, the transcutaneous electrical nerve stimulators, can be beneficial. They rarely work for just pure back pain alone. The mechanical issues, we talked about bracing. The inversion table, I rarely use on the elderly because of increased interocular pressure or dizziness. So that's not a good issue. Surgery, I'll defer to Dr. Brooks on. Injections, we've talked on. Psychological interventions. Many people that have these pains and have scoliosis, especially who wore Milwaukee braces as a kid, are almost like post-traumatic stress from dealing with it. And we have two great psychologists, Dr. Singles and Dr. Mergain, who really do a nice job on that. A lot of it, actually, they do more video these days than anything else. And that really helps them cope a lot of times. And integrative medicine, just looking at their diet, looking at the whole lifestyle, they're just down the hall from us on the west side. They do a wonderful job as far as looking at the holistic approach, and patients go for that. Question would be, like we were discussing before, what cases are better for rehab and which are better for surgical intervention? It depends. And if the big issue I go is pain or functional level and the patient's choice. And so that's, if they're getting a progressive neurological deficit, that's another story. but when you have a multi-level issue that has to be addressed, that has to be balanced out too. I missed this. I was just going to talk about other modalities. Acupuncture, massage are good. Biggest issue is insurance doesn't cover it, so that's part of the problem. Medications, I have a small number of patients that everything's failed, and I maintain on a low dose of narcotics on a scheduled basis, not an as-needed basis. If it's the only thing that works, it may be our only best choice. It's controversial, but there are cases where it's needed, and I also will follow the other medications that Dr. Segal and Sewer have talked about. Marijuana, we're close to Illinois, high number of patients go down to Beloit, pick up their gummies, and I just can't give them any narcotics if they're doing that, so I don't want to go to jail. So that's that group. So key points, aerobic exercise is the most effective. A simple exercise program works best. The things that I get a mileage out of, I tell a patient, for every pound they lose, there's 4 pounds less compression on the spine and extremity joints. So if they lose 10, they knock 40 off that. The thing I get more mileage out of is if in every pound of fat, there's 7 miles of capillaries. So if they lose 10 pounds, their heart doesn't have to pump a blood cell from here to Milwaukee. They remember that one. So those little ditties that sound kind of corny that they sell, okay? So it makes a difference on it. Yes, I'll send a few patients over for bariatric surgery. I tell you, Ozempic has been a godsend. It's you know, a few don't tolerate it, but it's made a big difference. And I've seen patients, you know, lost 50 to 70 pounds on it. So I've used topiramate in the past to try to do that. It's nothing compared to how good that is. So that's a brief overview. So I think as Dr. Schmidt was saying earlier, yeah, you gotta, you know, this being able to go back and forth in the clinic, you know, it's not a dump when we ask for a surgical referral. There are patients that I will send to surgery because they need surgery. There are patients that need to hear from a surgeon that they're not a surgical candidate. And so they're, you know, those are the two groups that I would send. We try to be appropriate in rehab. We have a great group of residents, and we feel like we're getting you pretty smooth referrals. But there's always going to be the glitches that occur. But going back and forth has worked very well, and I think that residents and fellows in neurosurgery are blessed to have such a good group to learn from, because I think this actually is the state of art care for neurosurgery in the country. I'll leave it to Dr. Brooks now. Thank you very much.
Thank you, Dr. Leonard. I'm gonna remember that 7 miles for every pound of fat. One, any kind of dad joke they tend to remember. Perfect. So when I was a resident, and then when I did my fellowship, spine deformity was definitely the most common topic discussed. It was really thought of as kind of like the apex procedure that you would do as a spine surgeon, and many fellowships, and even now to this day, really focused on the fact that they taught us how to do deformity operations. That was the upside. The downside was they didn't really focus too much on how morbid of a procedure it is, both for the surgeons and for the patients. And also really the data, I think, does show benefit, but also kind of suppresses a little bit of the risks. So what are we talking about? Dr. Leonard showed a lot of great images of scoliosis, but when we're talking about degenerative scoliosis and especially sagittal imbalance, we're really talking about patients who are leaning forward. Their spine is leaning forward of their pelvis. And you can see in this patient's case that they can't straighten that up, so their torso and their erector spinae muscles have to do work all the time when they're upright. This has been called the cone of economy. So once you fall outside of the cone of economy, where torso is out of balance with your hips and your feet and your pelvis, you end up having to do a lot of work, which causes back pain. In order to compensate, you often will be tucking or everting your pelvis, which creates some pain in the anterior aspects of your thighs and hip joints, as well as contractures, because you're always stuck in a flex position. And then also thigh pain, because you end up doing something of a semi-squat to try and compensate for this. Patients typically are fairly miserable from this, and have been dealing with it often for a very long time. So it is something that they have usually not gotten an early referral for. We found, looking at these patients and comparing them to normal patients, that as they decompensate from a sagittal component perspective, about greater than 5 centimeters of decompensation seems to have a deleterious effect on their function and pain. And then as we looked at like coronal imbalance, greater than 4 centimeters off of midline seems to have a higher likelihood of pain and dysfunction. So both of these are parameters that we have to think about when we're doing surgical surgery for these things. And you can see in this patient's case, he's has quite positive sagittal balance. He has loss of lumbar lordosis, so his spine is very straight. And so there's a lot of work that needs to be done to get him back into balance. There are many pelvic parameters that we look at, because the pelvis is somewhat of a fixed fulcrum within the balance of the spine and the construct of the spine. It of course can pivot around the acetabulum and the hips, but the actual angles, the sacral inclination, the pelvic incidence, and the pelvic tilt are all somewhat, especially the pelvic incidence is a fixed parameter within that, and so you have to incorporate that into the surgical plan. Depending on that surgical plan, that can require a whole host of surgical interventions, which go from being not too bad to being terrible. And so when we're looking at this slide, we're showing you different grades of osteotomies. So these are cuts made into the spine to try and improve the patient's lordosis or the overall balance of the spine. And going from grade 1 down to grade 6, I've never done a grade 6, by the way, but I've definitely done a grade 5. They become increasingly more morbid. It's much harder for the patients to recover. There's a significant amount of blood loss during the operations, tissue disruption, et cetera. And so it becomes quite a difficult procedure for the patients to tolerate. In this patient's case, you can see how he ended up with an anterior and posterior approach, as well as osteotomies, and then a T10 to pelvis fusion. And so it got him to where he needed to go, certainly. But the unfortunate part about this is the case overall can take many, many hours. This was early on in my career. It took about 12 hours to do this operation. And of course, with long procedures and open incisions, there's a high risk for infection. He ended up getting infection. So we ended up having all sorts of trouble in the long run dealing with that, dealing with treatment of the infection, getting good healing. There are benefits to doing these operations, and people can do well. Patients can do well. They decrease their disability indexes, as well as they get improvements in the SF-36 and improvement in mobility, improved biomechanics. You can see this study looking at gait and ambulatory motion when patients get their spinal pelvic parameters realigned with surgery can be beneficial. And we certainly see that their overall patient-reported outcomes seem to be much better in the operative groups versus the non-operative groups at 2-year follow-up. But it's a high risk and a long recovery. The published ranges of complications, morbidity, mortality, specifically morbidities, is somewhere between 12 and 60%. But we are always realistic and describe 100% chance for something to happen to you. It could be something you get over, or it might be something very bad. As patients' frailty worsens, they have a higher risk. So unfortunately, these are typically patients that are older. So we definitely have to try our best to make a judgment on how much their frailty is going to impact whether or not they can tolerate these procedures. I would say that my morbidity is more like 70% minor complications and 30% major. And certainly this is a year-long recovery, if not more, to get through the whole thing. And it's expensive. So this is the entire palette of instrumentation implants that we have to bring to an operation. And so that is way more surgical implants than you would typically see for our other conventional operations. And there are plenty of surgeons who have said that their hospital has asked them to stop doing these operations because they actually are they cost the hospital money rather than benefiting the hospital. So that, of course, on a patient per patient basis, it's important to take care of the patient, but it's also from a system perspective, you have to think about what value we're going to get from doing these types of operations consistently on patients. I don't do them very often. I know the fellows and the residents probably don't love that fact. I talk a lot of patients out of it, but I see all the patients for this. And it typically is a long conversation. I typically will see them at the initial visit, send them back for more conservative treatment, and really get to know them before we go through with any type of procedure. Because again, once they start having the complications, which don't really compute in the patient's mind, they actually you need to have some good rapport with the family and good rapport with the patient to get them through it. In conclusion, I would say sagittal balance correction for degenerative scoliosis can be beneficial, but carries more risk than other spine procedures by quite a lot. And again, surgical treatment can be considered after conservative therapies have been exhausted. That's the short form. I have a much longer version. We don't need to go into that. So we're going to go to our 2 cases. Any questions while we're transitioning? Comments? Resnick, what are your thoughts?
I appreciate the first honest deformity talk I've heard in quite some time.
Yeah. So again, for the residents, for the trainees, the deformity is kind of like one of these. It's kind of one of these. I don't know if the word sexy is appropriate, but it's like one of these bigger operations that we do in spine surgery. So it definitely gets a lot of press. Dr. Leonard, if you want to sit up here, we can share the table if you want to sit on that opposite side. So it definitely gets a lot of press, and in selected centers, I think it can be very valuable. The problem is that the way the training was rolled out was essentially, well, anybody can be a deformity surgeon. You can show up in Appleton and start doing deformity. But the reality is there's a much more holistic approach to treating these patients than just doing the operation. And then also a realistic understanding of what the long-term results are and what kind of other morbidity you bestow upon the patient when you try and make their x-rays look good. So, okay. All right, 75-year-old man with positive sagittal imbalance. I will tell you, of course, that he's this is not entirely accurate, but I'm going to make it up. Okay, he's totally healthy. He's totally nice. Okay, but no. So he's complaining of back pain. Okay, he doesn't have any neurologic complaints. And he has had a previous fusion at L5S1, and he does have a from that surgery. I think he got oh no, he does have a spinal cord stimulator that somebody tried on him. So he's not had much conservative therapy yet. So what are your thoughts on this?
Just on basics, I try to stretch out the anterior structures as much as possible. The hip flexors, the abdominals, get them, if you could stretch it out. I don't know how effective it would be and if he'd have the pain tolerance to do that. I'd put him in a support and get him walking or get him in a pool program. I'd emphasize strengthening more of the legs than I would of the spine and cardiovascular conditioning if you were thinking of doing a procedure on him. And then see what appropriate meds would be required for it. Wouldn't be in a big rush to do injections on if it's more actual type of pain. But see how his bones look maybe a little brittle. So I don't know how much he's going to tolerate on it. His biggest issue is getting his cardiovascular work up, maybe stretching him out, but that's going to be hard. And then the lower extremity strengthening.
Right. So I think there's from my perspective, there's a lot of expectation management that has to be dealt with. He's kind of gotten a treatment in the past, and I didn't have a chance to give you all the films, but he certainly, because of that old surgery, I was able to see what the decompensation has been over time, and the deformity has been over time. But the reality is that it should be a very slow, coordinated process to get these patients into surgery. It shouldn't be see the surgeon, films look bad, do operation. You need to really make sure that everything is that can be reasonably done, has been done from a conservative management standpoint. And then also when we talk about frailty, we talk about bone quality, we talk about all these types of things. The way I describe it to patients is there's no use planting in bad soil. So that basically that we're trying to make everything as good as it can be to consider doing an operation. It may not be that we end up doing an operation, but bone health and nutrition and all those types of things have to be optimized as well. So I would definitely sit on this patient and try and get them to do all the other things for as long as possible, and then eventually we'd be talking about an operation. So
the biggest feedback I get from patients when I say, look, it's going to take you 3 to 6 months to recovery, they say, I don't think I'm going to live that long. I don't want to spend that much time.
That happens sometimes too. And now thankfully, many patients self-select in this age group. It's actually, I would say that when this happens to people in their 60s, it can be much more likely that they want to proceed more into surgery. And so that those are all important aspects. And of course, they will potentially have different levels of nutrition, frailty, all those types of things, depending on which decade they're in. So, but from a resident standpoint, what do we think now? We're going to do the operation. I made that decision. Dr. Leonard tuned them up. Anybody? Sure. So yes, he's got a distended colon. He's got some other things going on. So that you would think like there's a significant comorbidities that might be worse. He might be made either worse by putting on their general anesthesia for long periods of time, or that you're missing something else that actually is they're gonna kill them faster. Yeah.
He's gonna need some osteotomies, probably like a T10 to pelvis, maybe some inner bodies.
Well, 5-1's done. Thank God somebody did that for you. Yeah. So you got the first one done, but
I think before you decide that, you need to do more measurements than just the positive side and balance. You're looking at PIL mismatch, first age, maybe 75 to get. You don't have to overcorrect, you have to get within a good range. And then there's a lot of data that shows like the T4L1 pelvic angle to matching those.
right.
Anatomy safe someone to perform something with like a T10 pelvis. I think if you are doing that, decide that this right thing, given balance.
necessarily answer your ways, but posteriorly, when I look at quadra to, the next screws in addition to S2AI to really kind of construct that. But I think the key here at the age is not overcorrecting it when you're getting them into a sweet spot where quality of life.
Okay, and then let's say you do everything right. What's their, and they heal from the operation. What's their biggest risk factor after that? Yeah, so even if we do a perfectly good operation, and that's the other thing that's kind of buried in the literature that is talked about a lot more now. They end up with yet another operation. It doesn't take very long before they're down for something else. So you make sure that you explain that to the patient also. This is probably the first of many operations rather than the first and only. Yeah. Okay. Next one, still degenerative scoliosis, not nearly as bad, right? You can see that the sagittal balance is not nearly as bad. Coronal balance is not nearly as bad. And I didn't get a very good picture of the hip, but they've got left groin pain. And then you examine them and it's really more of a hip examination than anything else. What do you think, Dr. Leonard?
The left hip may have a different shape to it than the right. It may be just a little bit off, and you can see an osteophyte laterally, like an impingement on the hip that could occur. When you get hip problems, the first thing you lose is usually your you lose your rotation first. In passive exam, you'll see it's really tight on that, and then they'll impinge on when you flex it up or adduct it. So you could try. I would try the physical therapy approaches on it first, with emphasizing low impact exercises. Put them in a cane to see if they're better. You could inject the hip, or if it's more lateral pain, just inject a bursitis, as we frequently do in clinic. But I would do a diagnostic injection into the hip capsule, see if that's where it's coming from versus the back.
Yeah, and I think that this is really important because the risk profile of hip operations is way lower than the risk profile of spine deformity operations. And if that gives patients relief, I think that's going to be a much more valuable procedure to send them to than doing an operation. However, as I was preparing for this talk, I found quite a bit of literature on the association of lumbar fusion and poor outcomes in hip replacement surgery. They think it's related to the change in flexibility of the spinal pelvis apparatus, and so that there is some association with if you do the fusion first, there's more complications with the hip joint itself, which is again adds fuel to the fire to tell the hip surgeon to do this hip surgery first.
Usually we encourage them to have the hip first, if there's both hip and back, just because it's a quicker recovery, and a lot of times we'll get rid of a lot of the back pain.
Yeah, that's what I tell them too. I just say, like doing hips is really almost like changing car parts now, and so that one may be the more reasonable one to try first, and if it fails, then we can move on to something bigger and better. So, any thoughts from the rest of the crowd for that? Cool. Thank you very much, Dr. Leonard. Really appreciate it. Thanks for putting together that great talk. Okay, last but not least, we got a really simple one, neck pain. Okay, we're going to talk about cervicalgia. Dr. Rudin is gonna be the non-surgical, and then we have Kath Pride in the back there too. He's going to give his perspective on interventions, and then Dr. Resnick. So it'll be a good cohort of discussion. Okay, thank you very much, Dr. Rudin.
You bet.
Okay, and this microphone works too. So.
Okay. There we go. There we go. All right, cool. Hello, everyone. Why is everybody sitting so far back? I brushed my teeth, really,
Hello, I'm Nate Rudin with the Rehabilitation Medicine Group, mostly at the pain clinic, here to talk about cervicalgia, specifically the non-surgical and non-interventional management. You know, the state of the evidence for non-surgical management of neck pain is relatively lousy. There's a lot of treatments. They don't all work awesomely. I figured I could just end the talk there and leave, but actually I thought you'd want to know some more stuff. There are a lot of studies, most of them small, many of them uncontrolled. So evidence is of highly variable quality here. There have been quite a number of meta-analyses and systematic reviews trying to put everything together. And almost inevitably you see, well, we reviewed 900 papers and 14.5 met the criteria. And so then they go through and boil it all down and try to give us the best that they can. So we really do need to up our game in the evidence world for the management of neck pain. And the outcomes measures used are highly variable. Pain severity scores are the most common. Your 0 to 10 scale. Functional measures like the Neck Disability Index, the SF-36, the PROMIS are less common, but they are out there. There's not a lot of standardization though. So that all said, let's actually take a look at what people are doing for non-surgical management of neck pain, what has some data behind it, what doesn't, and what should you do for your patient. One of the big difficulties, of course, is that neck pain has so many different potential sources, right? Like any spinal pain, you've got muscle, you can have pain from overactivity, you can have pain from overload and weakness, ligamentous sprain and strain, of course, and the various joints, the intervertebral discs, the zygapophyses or facets, the oncovertebral articulations. Then, of course, bone itself can be a source of pain, and you can have compression or traction on nerves. So with this huge number of potential pain generators, it's difficult to figure out what you do for neck pain. And when you take the evidence and look at it, most of the studies boil down to either radiculopathy with disc herniation, they're studying that, or they're studying non-specific neck pain, which means kind of everything else in a big bucket. You don't see a whole lot of studies just, for example, for facet arthropathy, but for those, we actually get some interventional evidence, and Dr. Pride will talk about that. Let's start with exercise. Exercise actually does modestly improve function and pain and is useful for a number of things. The emphases tend to be on things like postural correction and muscular re-education. Large numbers of people with neck pain they will have a forward head posture. They are hyperactive in the extensor muscles. They're not using the deep flexors very well. And your neck muscles get very annoyed when the head is forward. If the head is balanced properly on the spine, the head weighs X. As soon as you start bringing the head forward on the neck muscles think that the head weighs at least twice as much. They have to work twice as hard just to keep your skull balanced on top of your spine. So correcting posture itself can often take some pain down, and that kind of muscular re-education is important. There's also strengthening of various kinds, stretching of over-tight or shortened muscles, light aerobic exercise in some cases. Generally, a combination of 3 or more types of exercise yields a modest improvement in function and pain. And cervical traction, if used judiciously, can amplify the effect in patients where spasm is straightening the lordosis. You actually can ease it a little bit with traction, but you have to apply it awfully carefully. Okay, what about manual therapy? People go to chiropractors, they go to osteopaths. Annoyingly, the literature doesn't do much of a job of differentiating between the two types of manipulation, although in practice they are quite different. Regardless, manual therapy is shown to produce modest reduction in neck pain and radicular symptoms, modest improvements in function. Everything is short term. We do not see long-term sustained benefit. If exercise is added, the efficacy of manual therapy is improved. We have to be very cautious with any sort of chiropractic manipulation, or for that matter, traction in people with quite advanced degenerative disease and in hypermobile individuals. The risk of injury to neural elements is a lot higher in those people, particularly with high velocity, high amplitude manipulation. So people come in and say, well, can I go to the chiropractor, get my neck cracked? Well, maybe not. Either, you're so loose that you have 90 degrees of cervical extension without working hard and without any pain, or you have so much arthritis that, we really worry about what kind of osteophyte they might bust loose or cause other problems. Cervical traction, the literature is iffy. It does separate and decompress painful discs and facet joints to some extent and may reduce pressure on nerve roots. It does help restore the normal cervical lordosis in somebody who has spasm, yanking their neck straight like a ramrod. There is temporary reduction of radicular pain demonstrated in the literature. In several studies, it will reduce mechanical pain and improve function if it's part of an exercise program. If you do it all by itself, you don't get much except maybe a few hours of relief, and then everything goes back to square one, which makes sense because things collapse back down. So useful as part of a program, not so much by itself. Okay, so I was just in Las Vegas, and that sign literally was on the highway. I don't advocate for using crawfish when you're giving the massage, but massage is shown to produce mild short-term reduction of neck pain only, but no functional improvement, not really helpful in radiculopathy. We do not really recommend it routinely as anything that's going to provide long-term relief, but it does make people feel good for a little while. And with that picture on that slide, you will remember that forever. Okay. What about acupuncture? We get asked about this all the time, and it is offered by our integrative medicine service. We do know that it mildly improves function over the 6 to 12 month period in neck pain. It modestly reduces neck pain, but not for that long a period of time. There is evidence for mild improvements in neck range of motion, pressure pain threshold, and neck disability index in people with mechanical neck pain. Does nothing for radiculopathy. One of the big difficulties with acupuncture in the literature is that the type of needling is varied, the needle sites vary, the placebos they use vary. There are a lot of uncontrolled studies out there. And in many studies, it was pointed out recently by a neck pain task force, there's not very good control for patient expectations. For example, if you're getting your acupuncture versus sham acupuncture treatment in a place that is an acupuncture center full of acupuncturists, you're going to have very positive expectations for benefit, and that can be confounding. So I saw in my review of the literature skepticism on some hands, cautious optimism on others. Is it going to hurt people? No, the risk of infection is incredibly low. Is it curative? Not really. Some people feel a bit better. Moving to another sort of needling without going to image-guided intervention is trigger point injection. Myofascial trigger points are definitely a thing. They're these hyper-contracted bands of muscle. Any of you has had these. By the time you're done studying for a board exam, you've got trigger points in your upper traps at the very least. These can be inactivated by putting a fine needle into a trigger point, needling in and out and eliciting a local twitch and waiting for palpable relaxation. You need to use that technique. If you just put a needle in, inject, and come out, you haven't done a trigger point injection. There is evidence for reduced neck pain with a duration generally of between 1 to 8 weeks. It doesn't reduce radicular pain. Anecdotally, there's improvement in cervical range of motion, but I'm darned if I could find a study that actually backed that up. I do see it in my patients in the immediate term and for a few weeks afterwards. But after that, if you've added exercise and they're doing their PT, they'll take advantage of the pain relief and relaxation, and they will improve. If they don't do anything except get a shot, things tend to just go back to where they were. Does it matter what you inject? You can use local anesthetic. You can use saline. Doesn't really seem to matter. You get the same effect. Dry needling with no agent at all is also helpful, but not quite as well tolerated by a lot of people. There is no reason to put a corticosteroid in a trigger point because they're not inflammatory lesions. If you biopsy them, you don't find anything except muscle. The only modality that allows us to visualize trigger points is ultrasound. And you can see hypoechoic areas where these things exist. So we finally do have a way to image them at least. What about modalities? Some surprises here. TENS units, transcutaneous electrical nerve stimulation, no convincing evidence of efficacy for neck pain, although the studies are lousy. No convincing evidence of effect for heat and cold beyond very temporary relief. Interestingly, there's a small set of evidence now supporting a modest benefit for acute and chronic neck pain with low-level laser therapy, which is basically a deep heating modality, and which is something that I scratched my head and said, you got to be kidding. But actually, there are a few reasonable studies suggesting this might be helpful. But again, modest benefit and short-term relief. Cervical collars, usually not helpful, except perhaps short-term for acute, very severe pain where motion and muscle activation are problems. Otherwise, they don't seem to be beneficial, and numerous studies flagged the fact that appearing in a cervical collar in public or in a courtroom is sometimes very beneficial to the patient, but it is not necessarily helpful to them in terms of medical benefit. And kinesia tape, the elastic adhesive tape, which imposes a flexible mechanical barrier to motion. If you put it on the neck and you bend against it, it restricts you a little bit, also provides some proprioceptive augmentation. There are a few high-quality studies of the use of this stuff. It does look like it will mildly reduce pain short-term, and if applied correctly, people use their cervical flexors more and their extensors less. Does not help for radiculopathy. Okay. We also use cognitive behavioral therapy when dealing with chronic pain in general. We have health psychologists in the pain clinic. It can be done individually with groups or over telemedicine. It does not have any significant effect on the pain itself. If people come in thinking they're being referred to health psychology so that it'll make their pain less, no go. What it does do, the effects are modest, but they are durable, like a couple years out. It improves health-related quality of life. It improves coping. It reduces anxiety, depression, and pain-related catastrophization. So people cope better with their chronic pain and manage to function better if they do CBT. So it is one of the more beneficial of the modalities we use. Okay, now let's go to medications. Here's something else I saw in Las Vegas. There's a place called Omega Mart, which is this bizarre satirical grocery store. Anyway, Corn PM is basically about as effective as most of the medications I'm going to tell you about. The nonsteroidals, oddly enough, have not been formally evaluated specifically for neck pain, except topical diclofenac, which was shown to have moderate short-term efficacy. In low back pain, NSAIDs can produce modest reductions in low back pain, but we really haven't done the studies for cervicalgia. Acetaminophen, there have been multiple studies showing no evidence of significant pain reduction for chronic spinal pain. Acute, it can be helpful. Chronic, it doesn't seem to do very much. What about the muscle relaxants? Cyclobenzaprine has mild but consistent efficacy at reducing pain. In studies of neck pain, no benefit for radicular pain, but cyclobenzaprine is a tricyclic antidepressant. It's one methyl group from amitriptyline. It can cause sedation, hypotension, even arrhythmia, and many people are so sedated they feel like they get whacked over the head with a hammer, which is a physical modality we do not recommend. There is fair evidence for the ancient muscle relaxant orphenadrine. Don't give anybody carisoprodol That's a drug that's metabolized to meprobamate, which is a highly addictive barbiturate. There is insufficient evidence for other drugs in the muscle relaxer class. There are the antispasticity drugs, which are used a lot off-label for this sort of thing. There is fair evidence for pain reduction in regional musculoskeletal pain for tizanidine and some neuropathic pain reduction. More risk of dry mouth. This stuff is analogous to clonidine, so dry mouth, hypotension, those are the sorts of things to worry about. The evidence is very scant for baclofen, and the outcomes are inconsistent, but it also has some neuropathic pain reduction. It can occasionally cause weakness, particularly if anybody has spasticity that they are relying on to stand on. So if they've had an upper motor neuron lesion, and they're spastic, if you give them too much baclofen, they'll get weak and floppy and they can't function properly. Then there are the adjuvant analgesics. It seems like we throw gabapentin and pregabalin at everything. They do reduce radicular and other neuropathic pain in multiple studies, but not really musculoskeletal pain. Duloxetine does seem to reduce neuropathic and musculoskeletal pain. That's an SNRI antidepressant. And it's actually got FDA indications for that. The tricyclic antidepressants are effective for neuropathic pain, but the side effects can be quite problematic, especially in older patients. What about the opioids? Well, we try to stay away from them. Certainly in chronic pain, they've not been proven, and there have been studies, they are not superior to placebo for non-specific acute neck pain, and they're not superior to placebo for chronic neck pain in general. There were a couple of trials stating that pretty definitively within the last couple of years. Opioids may be appropriate for a small subpopulation of individuals with chronic neck pain, you know, your people with multiple surgeries, with chronic radiculopathies, basically people for whom everything else has been tried and for whom the contraindications are outweighed by the potential benefits. There are very few of those folks out there. They exist, but the data are insufficient to really give us solid conclusions. By and large, we avoid that class of drug in this population. Okay, so that is a whirlwind tour of where we are with non-operative neck pain management. The bottom line is that not all of the therapies we routinely use have been proven effective. The effective therapies have modest, but usually short-term results. There are no clearly superior treatments. We actually seem to get a little bit more bang out of exercise, out of trigger point injection, and out of cognitive behavioral therapy. The non-drug therapies, though, are generally speaking less risky than the medications. And so if you're looking at incremental benefit from just about anything you're going to use, the non-drug therapies, many of them are worth a try. And we should always remember, if you're suffering from pain, an incremental improvement is usually better than no improvement at all. So while our evidence is not spectacular, we have a broad toolbox, and an awful lot of these things are worth trying. Thank you so very much.
Of course, I'm often telling patients that the era of when we used to try and treat neck pain with surgery is thankfully getting farther and farther away, but occasionally we do have to do it. So thank you, Dan.
Thank you very much. It's always great being between the audience and the door at the end of the day. So I'll try to make this as brief and mildly entertaining as I can. Do these buttons work? Yes. This is an irrelevant disclosure. So cervicalgia is the same as neck pain, in case you don't know, which is the same as aging and has bred a nice cottage industry. I used to talk about Resco Industries developing a back belt for the treatment of acute low back pain, and that I was going to market it in Sky Miles magazine. Well, Sky Miles magazine doesn't exist anymore, but Amazon does. And just a quick perusal of Amazon reveals a whole bunch of really, I don't know what you do with those Lego looking things. I'm kind of afraid a little bit, but anyway, a whole bunch of things that are out there. So I see this as a potential investment opportunity. Those of you who have some extra cash and want to invest in the neck belt, please come see me afterwards, and we'll try to get something going. But in any case, there are certain indications for cervical surgery. Radiculopathy we talked about, myelopathy we talked about, instability we may touch on. This can be due to trauma, can be due to tumors, can be a degenerative instability, as Brad just did a case at Merida yesterday for degenerative instability. You can do surgery for disabling deformity, which we do from time to time, and you have combinations thereof. And in general, if you have these types of issues, there is literature to support the performance of these procedures, and there's generally pretty good data indicating that the surgery works for these procedures. All of these aforementioned conditions can be associated with significant neck pain, and by and large, surgical intervention for these other things, radiculopathy, myelopathy, deformity, instability, is generally associated with improvements in neck pain. So sometimes the pain relief is due to nerve impingement, sometimes it's due to instability, sometimes it's due to removal, due to a pain generator, a bad disc. And when we do these operations, neck pain generally gets better. And there's been a couple of meta-analysis looking at the effect of these types of surgeries on neck pain. And in general, the results are pretty favorable, which is what you would expect. However, the important caveat is that none of these patients were operated upon for neck pain. They were operated for something else that's associated with neck pain, not the neck pain itself. So in this paper, this is Jim Harrop from Jefferson with a study group. They looked at a number of studies encompassing 5,200 patients, and they found that overall, patients who had radiculopathy had improvements in their neck pain, and with neck pain dominant patients doing worse than arm pain dominant patients, which is kind of what you would expect. When you have a hot radiculopathy, patients tend to improve more when you improve the radiculopathy. If it's more of a chronic neck pain issue, it's not going to be so good. The Cochrane Review also did a review of this. They did the exact same thing that the Washington State Workers' Compensation Board did. They pretty much asked the wrong question of the literature and found they couldn't really answer the question because they were looking at neck pain in isolation and not looking at neck pain and arm pain, or neck pain and disability, or neck pain and neurological function at the same time. Bogduk, we were talking about injections and ablations. I have to talk about Bogduk. He's sort of the father of this. He has proposed that cervical discs are a viable source, are a source of neck pain as a pain generator, as it were. I was around for cage rage back in the day, and I can tell you that this argument was used to push a lot of sort of crazy, unnecessary procedures going forward. Fool me once, shame on you. Fool me twice, shame on me. Not buying it. And in fact, even Bogduk says the incidence of this in the cervical spine is probably low, and there's really no clinical evidence to support treatment decisions based upon this hypothesis. So it may be true, but no one knows what to do with it. Now, is the absence of proof the proof of absence? Are there patients who benefit from surgery for neck pain? I know all of these authors, and most of them are not criminal. I do have a bit of an issue with the ECK paper where 20% of their patient population operated on with ACDF did not have radiculopathy or myelopathy. That to me is quite off in terms of the bell curve of spinal aggression. But there are reports of patients getting better when operated upon with ACDF for neck pain. And the article by Wang et al. Is a pretty reasonable one when you read it through. So the question, is surgery a reasonable treatment for neck pain in the absence of radiculopathy, myelopathy, instability, or deformity? Is there any basic science evidence? No. Is it safe and inexpensive? No, it's expensive and dangerous. Are there reliable results in the literature? No. Is surgery ever indicated for neck pain, for isolated neck pain? Probably not, but maybe, I don't know. And who would be a candidate for such surgery? And this is a very important issue. And I think it comes up with the injection talk we just had previously, where people are being treated with multiple modalities for non-specific symptoms. This is an undefined population, and they're very vulnerable. they'll do whatever you tell them if you say there's a chance it's going to relieve their pain. Than brought this up in the deformity in the deformity population. You see, I can do this operation, but there's a very high complication rate. It's like, doc, I can't be any worse than I am now. Well, that's a lie. That's a real, we know that that's a lie. But that's what people think. So this is a very vulnerable population. They're very influenceable, and we need to be very, very careful when we're dealing with this patient population. Have I ever operated on isolated neck pain in the absence of other indications? Yep, twice. This is back in the late 1990s, early 2000s. That's exactly how old I am. Both were relatively young women with disabling pain and single level dramatic degenerative disc disease. So the entire spine looked perfect except for one level, C3-4 in one and C4-5 in the other. I did those two operations. The first one did reasonably well. So then I did another one. That one was an absolute train wreck. And I've not done one since. And I'm not planning on doing any in the rest of my career. So in summary, surgery is effective for the treatment of radiculopathy, myelopathy, instability, and deformity. Axial neck pain relief is common, but not guaranteed when surgery is performed for those indications. In the absence of those indications, there's minimal to no evidence to suggest that surgery is an effective treatment for axial neck pain. And since surgery is never safe or free, it's generally not indicated for axial neck pain alone. And I think it's pretty straightforward.
Thank you very much. If we could get the guest speakers up on the panel. One more chair for everybody. Thank you. Okay, so let me make sure I get us to the right case to start. So midline neck pain, left C6 disc herniation, no neurologic findings. So this case.
Clearly, Dan's going to operate.
He's a multi-level corpectomy followed by
Right. So I know we know from your guys' talks essentially what your personal answers are going to be, but I think this is not an uncommon situation to be faced with in clinic. Is boy, there's something there, and that again, the radiologist has pointed that out. They have not pointed out all the other areas of pain generators that could be there, but your clinical exam is more consistent with neck pain. So Dr. Rudin, maybe you could start,
Sure. Yeah, and on my clinical exam, I'm going to want to be looking at motion. What are they doing? They look like they're quite straightened through the cervical lordosis. There's multi-level desiccation, lots of osteophytes. Certainly, this is someone whose neck is not going to move spectacularly well, particularly in the lower segments. So a lot has to do with the exam, first of all, where the pain is in the neck. So if you palpate over specific structures, if you've got pain over facets, for example, and increased pain with loading those, with combined extension, side bending, may give you a clue. If there's a lot of muscle spasm, sometimes it's very difficult to sort things out at all. I will often lie people down at this point and repalpate with them supine or prone, because then you shut off the erector spinae and you can actually really feel what's going on a lot better that way, get a better sense of what's going on. If there are particular motion segments that look really painful, well, let's see, right now, unless there's any contraindication, this is somebody that I would at least want to start after a good physical exam and postural assessment. May well be somebody who would benefit from some physical therapy. And I would usually begin there. They're going to need some help getting those neck flexors turned on, getting those extensors turned off somewhat, getting that head a little bit back with relation to the cervical spine. and improving the posture as a whole, hopefully getting some of that muscular pain out of there. Gentle traction may be helpful in individuals like this. And depending on how they respond to that, or whether we see any specific signs, they might be candidate for trigger point injection and or facet procedures.
So, yeah, so let's talk, Dr. Pratt, if you would, you know, how would you approach, you know, and you're going to be repeating some of the things you already said in your talk, but, you know, as patients, how do you localize where you're going to start? We're on to facets, we're on to.
Yeah, I think what Dr. Rudin mentioned, those are all the things that I would do too, prior to engaging in any interventional workup, right? You want to be conservative first. Regarding his images, I agree, very noticeable loss of lordosis. Actually, great dentition, with the exception
Yeah,
with the exception of the overbite. But
sorry, I flipped it back, but yeah.
But no, just a focal examination of the neck, some special exams, Hoffman and facet loading, pretty extensive palpation, both up and down, to see if we can identify any trigger points, just because that's probably the least invasive thing that we do as far as interventions are concerned. If there are no real true neurological findings and no radiculopathy, I would not recommend this go through for an epidural right now, because not really targeting anything either, with the exception it's very small, maybe causing pain hernia, which or herniation, which is unlikely at this point. But again, he has to go through all those other pylons of physical therapy, something like trigger point injections, before I'm really going to consider anything larger than that. I think the next thing, as far as conservative to invasive goes, is something like medial branch blocks or targeting osteoarthritis of the spine. And after the radiology read and loading those facets, that might be the next step as well, as long as physical therapy was trialed. And then I'd also ask him about any referred pains, you know, him or her, see if it was male.
Yeah.
But does this pain refer up into the head? Does it go into the shoulders? What brings it on? Things like that.
So, so perfect. And so after a lot of trials of facet mediated treatments, you finally arrive at, maybe we'll try a transforaminal injection, and then the patient gets better for a few hours. Dr. Resnick, would you take the bait?
That's irrelevant. And yeah, I would almost find that as a sign of somatization. To be honest with you, that'd be so unexpected, you know, type thing. But I'd like to comment on something that Nate was talking about. I'm going to date myself, but this is sort of like a hair club for men moment. I'm not just the president, but I'm a client. So I've had a couple of herniated discs. I'm currently rehabbing a shoulder. The influence of aerobic exercise and the muscle retraining, it really works. And so getting patients to buy into that and participate in it I think is extremely helpful, and is one of the more valuable things that we can do, because when they're in the office, we're the authority, right? You know, and you know, but I mean, it really does work a lot. And I just can't emphasize, you know, how much it can work. Now, obviously, someone's got a, you know, straightforward neural compression or something that's dangerous or instability, that's a different story. But for a lot of these patients, getting them enthusiastic and like Nate said, getting them doing things that they're actually going to do. You can't give them a 27 exercise regimen and expect that to happen. But getting them to participate in that, it really helps. But there is no surgical management for this.
Yeah. So the two comments I want to make, first of all, is that because of the MyChart situation, where patients get their findings delivered to them, and then they look it up online, this is where you run into this problem quite often, is they say, well, sure, you could do these trigger point or facet joint injections, but what about the disc?
Fix that herniation.
And all you got to do is fix this thing, and it's going to fix me. They see it online, et cetera. So it is very important that you have to kind of give some reasons for why this doesn't make sense to the patient and their family, et cetera.
Yeah, one more to me too. Just regarding the importance of physical therapy, I'm oftentimes our system is very good at, especially when patients get sent eventually to the chronic pain management clinic, these patients have undergone a lot of physical therapy. Whether it was the right kind of physical therapy is one thing or another, but at least they've had it. And so I oftentimes will be floored when I ask that question and the patient will say, well, no, not really. And sometimes these are patients who have seen out in town pain providers or APM, and they'll be like, no, I just, get my injections. And I'm like, 14 years it's been. So, so yeah. And alluding to what Dr. Leonard said, the best type of back brace is the brace the patient will wear. The best therapy that they do physically, or physical therapy that they will do is one that they will do, right? The one that they will participate in. And so it's incumbent upon us to really encourage them to explain why this is important, why it will work, why it is one of the few things that we can do that will actually get them to feel and be better, rather than the quote unquote Band-Aids that we sometimes do when it comes to injections or medications, but symptomatic management. So
yeah, I think that's very important. And then there's just the anchor effect of these studies. These studies really pull patients into wanting a treatment, and they have a hard time getting over it.
Right. And you have to set the expectations. Exactly. You have to explain why you're prescribing what you're prescribing and what you want them to do. And yet not all physical therapy is the same. If it's just modalities, it's not going to get them very far. That's what the evidence tells us. If they're actually doing the work, they're going to feel better. But they want the sexy thing. They want a sports car and we're selling minivans. And that's basically the problem. We need to set those expectations. As far as, well, why don't you treat the disc? My answer is, look, it's hard to take a picture of pain.
Right.
We can take a picture of all kinds of things, but you can have a problem. It doesn't mean it hurts. We feel that this is what we need to be doing. And of course, we have some statistics to back up that if you take 100 people with no neck pain and throw them in an MRI, 50 of them will have abnormal cervical MRIs. So doesn't mean that that's the cause of the problem. Sure, we could lop it out, but the risk of having a great deal of trouble is definitely there. And just because something looks a little abnormal doesn't mean that you need to fix it.
Perfect. I won't take you guys through the second case because we'll probably rehash the exact same conversation again. But I do think this is really, really valuable because, for us as the surgeons, although we kind of hear it peripherally, seeing the evidence that exercise is really beneficial, seeing that there's evidence out there is really valuable for us to tell our patients. And I totally agree. So when I describe physical therapy exercise to patients, I say, look, it's going to be like brushing your teeth. It's not going to be this thing where you have to go to the gym or even go to PT. You got to learn a series of exercises and just keep doing them. And then the other thing I like to say a lot is, your mom was right. You do have to sit up straight and, that kind of stuff. So great. Any other comments from the rest of the team? Any other questions? Yes.
Going back to that first case.
Yes.
What if he did have like intermittent radiculopathy that correlated?
If he had radiculopathy?
Yeah, but
Did he get an operation?
Intermittent.
Yeah. So I don't want to steal his thunder entirely, but his the data he was presenting was that scenario. What is it? We've got neck dominant versus arm, dermatomal or radiculopathy, and sorting those things out. And I don't know what your thoughts are.
Yeah, if he has radiculopathy, he's going to get an operation. The line I use is, if when you're trying to talk someone off a cliff is, you came in here needing brakes. I'm not going to change your muffler.
Yeah.
It's that's not your problem, type thing. But if he has radiculopathy, then you treat the radiculopathy, and there's a reasonable chance his neck pain will improve also.
Yeah. So that in that scenario, the data that Dr. Resnick was presenting kind of gives you that understanding of, hey, the neck pain is not it's part of your problem, but not the only part of your problem. And there is a reasonable expectation that at least we'll take care of the arm pain. If that's enough for you, okay. If that's not enough for you, well, there's only a soft maybe that you're going to get the neck pain.
Even if the neck pain was like the main thing, but it was like also there's a couple.
Well, if someone has a radiculopathy and they have neck dominant pain, if you treat the radiculopathy, they still can get better. The neck can improve. But if you take someone who does not have radiculopathy, the chance of getting better is much, much lower. And I don't know why. It just is. Probably because we can identify the
And
pain
none
generator.
of us know why. I was actually fascinated to hear from Dr. Rudin, that you can see some of these things on ultrasound now, which I think is actually really, really valuable. I'm constantly telling patients that the MRI shows a lot of great things, but it doesn't show where the muscle problems are, and that's usually the problem. Yeah. Okay, yeah.
I have a comment on the midline neck pain.
Yes.
It's in my experience, facet joint injections or treatments don't work because facet joint pain is either bilateral or unilateral. Classic midline pain.
Yeah.
It doesn't work.
Do you think that's more of a myofascial?
Posture related or
Yeah.
muscle related issue.
Right, need a Resco neck brace.
I have yet to find a
Wood right in the
treatment for
front, right?
individual midline, whether it's back pain or neck.
Yeah, right. Yeah, the amount of inflammatory pain from the fascia or the soft tissues is really, it's a real challenge for us. Yeah, keep going.
Question for you. So regarding midline neck pain, have you done or do you support interspinous ligament injections?
I've done those, but I'm not convinced.
Yeah. I haven't. I've seen your trainee, Dr. Seward, do them before, so I'm just curious.
Because Jim would send them to me and I would do it because I personally will not order it. I'll do it if Jim or anyone else
I have
orders it.
those
And I don't
procedures.
like, I'm not impressed by it.
Okay.
Of course, we have interspinous ligament spacers people are sticking.
We have
No,
it. We have
spinous spacers.
We sure do. We have anything you want. Anything you want. I'd like to thank everybody for coming today. This was a great symposium. I learned a lot. I hope you did. Tomorrow is the physical part. So we're doing surgical procedures in the lab starting at 8 a.m. Please bring clothes that you don't mind getting a little bit messy. If you have scrubs, that's better. We do have, of course, protective gear for you. And we'll all get a chance to learn together. If you come and say, for instance, the rehab providers, the non-surgeons come and they really feel like, the best thing to do is kind of team up with the surgeons so you can kind of get a little bit of a mix so that you can kind of move through the anatomical dissections a little bit more efficiently. And then vice versa. I think you guys could learn a lot from the standpoint of seeing where the injections are and seeing looking at all that kind of anatomy. So I think these are all the good things to do. So thank you very much.